Hello check 1 2 3. Hello check. Hello check 1 2 3. Hello check check. Hello check 1 1 1. Hello check check check. Hello check 1 2 3. Hello check check check. Hello check 1 1 1. Hello check check check. Hello check 1. Hello check 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 1 2 3. Hello check. Hello check 1 2. Hello check check check. Hello check 1 2 3. Hello check. Hello check 1 1. Hello check 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 1 2 3. Hello check. Hello check 1 1 1. Hello check check check. Hello check 1 2 3. Hello check check check. Hello check 1 1 1 2. Hello check check. Hello check 1 2 3. Hello check check check. Hello check 1 1. Hello check check.
Good morning, everyone. A fresh day begins, and our day 3 of DRS. With guide us through, I am delighted to welcome our distinguished chairperson for this session, Dr. Pratap Jetwani from Rajkot and Dr. Abhay Sahu from Bhuvaneshwar.
So good morning everyone. Welcome to the third and final day of DRS. A debate between two stalwarts. You all know the one person who has made change possible in NHS UK, European countries, and the one person who is trying his best to make change possible in India and South Asian countries. So to kickstart the debate, I think first 10 minutes to each and then 5 minutes for rebuttal, if everyone agrees. And before we start the debate, I would like to have an audience poll. How many of you feel that implementing UK-like health policies in India is a cakewalk? Only Manoj is there in favor of Partha. So Partha, you have got a tough job to do. So I will invite Dr.
I'm going to say the answer is yes, and I'll tell you why it's yes. So first of all, let's put some context, right? Before we begin. The UK population is smaller than the population of West Bengal. Right? West Bengal is one state out of 29 states, apart from other union territories. GDP contribution in the UK from the government is 14%. Right? In India, it's 3%, whatever it is. Healthcare is a choice, etc. UK healthcare is struggling as well. So don't believe for a second that UK healthcare is fantastic. Anybody telling you this, Simon is in the audience, is not true. So first of all, UK-like health policies, access is struggling, education is struggling, cancer care is struggling, everything is struggling. So when the debate topic is we're going to bring UK-like health policies, you need to specify it needs to be in diabetes, right? That's number one. Number two, here are some facts, and I've shown you this about what happens in India and where we are. Now, is it possible to change things in the world of type 1 diabetes? If you can see, in this country right now, if you can bring in insulin strips everywhere else, you'll be able to improve things. And over the last 5 to 7 years, things have already improved. It was 48 years of healthy life years used to lose. At the moment, it's 39. That is what already has happened in India. And these are some examples of good work already happening. Uran, Archana, go there and have a look. Is it a cakewalk? Well, Archana is making it a cakewalk there. And then we have seen about what's happening in West Bengal. You've heard about this, so really good examples of work are happening everywhere. Again, more examples of work happening, patient-led, people living with type 1 diabetes, etc. So what is it that you're trying to implement? As I said, access is struggling, cancer care. So is this about type 1 diabetes? That's what you want to see. If you look at the debate topic, it's about who would like to implement UK-like health-like policies. Well, I wouldn't suggest you try and implement UK health-like policies in India because we are struggling as it is. If it's about type 1 diabetes care, this is where it was. Type 1 diabetes in UK were poor compared to a lot of European countries in 2018. Arrival of technology, we had leadership team, outcomes have improved, DK, hypos, etc. It's not money, it's passion, drive, and leadership. and what takes us forward. Very few areas of the NHS have actually had improvements since that time. Type 1 diabetes has done that. So the first thing you need to improve things and whether they can make cakewalk is leadership, which you already have from Banshi. Banshi is the one. In 2018, I met Banshi in Ahmedabad. Do you know what he said to me? Tension mat kar, ho jayega. This is what he said, which translates into don't have any worries, it will happen. I have no idea why he's debating against me. The only reason I came to India was because of Banshi. Otherwise, I was very happy coming and seeing my parents and going back home. And now look at me, I'm coming here on a Sunday, I'm standing here debating against the man who made it possible for me to come here. I think it's completely wrong. This debate is completely false because the man who convinced me to come around and help here is now trying to tell me it's not a cakewalk. That is impossible, correct? But you also need to remember what is a cakewalk. It's a very important thing. Straight away you think cakewalk is the English word. No, it's not. The cakewalk was actually a dance developed from the prize walks in African cultures. The fluid and graceful steps of the dance may have given rise to the colloquialism that something accomplished with ease is a cakewalk. Banshi is leading this cakewalk. I cannot see how type 1 diabetes. How many of you know of Banshi Sabu? Hands up. Everybody? That's it. That's it. If you know Banshi Sabu, do you have any debate in your mind that things will change? Who has a debate that Banshi Sabu cannot change type 1 diabetes care? Anybody? To convince the last person, which is the only person left in this room who doesn't believe that Banshi can lead this cakewalk, Manoj, I am here to help. So you have absolutely no worries, no concern. This is definitely happening. But let's look at what we have achieved in the country. Type 1 diabetes, turnaround of health lives, a keen group of those with lived experience sitting in the audience. This is where we are. All jokes aside, 2018, we didn't have any of those. Now we've got a type 1 diabetes focused conference. You've got meetings where type 1 diabetes is discussed regularly. You've got people with lived experience sitting in the room doing things. And as I said, leadership from Banshi himself, and I don't mean that just in a jocular way. You all know the leadership he provides. That's where we are. International conference recognition, EASD, ATTD, everywhere we talk about where things are. And India is now seen as a template for many other countries to look, learn, adapt from. That has happened from all of you. We have in the audience the organizers, Purvi, Manoj, look at the work you're doing with the foundation itself in Mumbai. How does that happen? It's small things that come together to make it happen. I think it's very, very important to remember that. I've used this slide before, and I think it's very, very important. But more than this slide, I'm also going to tell you of a very important line that Shah Rukh Khan once said. People asked him in an interview, why do you always say you are the best? Why do you always say, is it because you're arrogant? And he said, no. He said, if I wake up in the morning and if I can't convince myself I'm the best, how can I go and convince others that I can be the best as well? And I think there should be no doubt. Everything starts from a point. And you've got Simon in the audience. He can tell you the history of the NHS. The number of people who will go around and say at that time, it will not be possible. It's possible. It's possible. That's why you're all here. It's possible. That's why the things are adding up. And I think the feedback of that will come from the people living with type 1 diabetes themselves. Do they feel there has been progress? The answer is, I think there has. And I think that's what you need to remember. And I'll finish this by saying one thing and one thing only. Change happens not because of money. Change happens because of dedication and focus. Change happens because somebody turned up and said, humko ye karna hai, right? That's what's happened. The whole world of Indian independence happened because a few people stood up and said, we want to bring change. Everything that's happened in this country. And I wanted to finish by acknowledging two groups of people. One is the group of leadership that is in this country. We are here because of that. You know, Manoj, Banshi, Shashank, Bridge, everybody has contributed to bringing us here. It is important. I always ask people to look back where you were 5 years ago. If you were there 5 years ago and you're here now, in 5 years' time, you'll be far, far ahead of where you are. That's the important bit. And finally, also to say that the people with the lived experience and how much they've contributed to where we are, the platform that they use to bring it. So is it a cakewalk? We can debate it about the terminology of it, but I think if you start from the point already saying it's going to be difficult, it's going to be tough, then you will always struggle to get there. Your aim, and I finish with this, if you aim for the moon and fall a little bit short, you still made a hell of a long way away from where you started off. That's always important to remember. Thank you very much.
So I will now invite Dr. Bansi to tell his story about why it is difficult to implement UK-like health policies, particularly in the field of diabetes.
First of all, thanks, Partha, for your wonderful presentation. And you are always a very motivator. And I have a few disclaimers before I start this debate. We are deeply patriotic and proud Indians. We hold immense respect and faith in our government and healthcare system, and which serves a population, large population, 1.4 billion. I am honored to serve as a board member of our national program for prevention and control of cancer, diabetes, cardiovascular disease, and stroke, and particularly in a national health policy for type 1 diabetes care under Government of India, Ministry of Health and Planning Commission. Dr. Partha, my close friend, and he is known for pushing equity for access. We Indians are proud of your work, what you are doing for UK and what you are doing for India. That's very important disclosure. And the debate is designed to understand type 1 diabetes gaps in India. So we are primarily, it's not for UK health policies overall, it's primarily for type 1 diabetes gaps in India and talk on future solution. We know that from 2017 we are meeting, first time I met him in Diabetes UK meeting, and then we were there in US, and then we planned type 1 diabetes conclave, and many more things. And since last 7-8 years, we are working very together. I deeply value the contribution of healthcare professionals, advocates in type 1 diabetes field, and my perspective comes from my clinical experience and observation which we have done in last 15 years. So we have done a lot of changes, but what we are saying that it's not so easy. Implementing NHS-like healthcare policy in India would be a cakewalk. Anything that helps to type 1 diabetes care, I will never say no. I will never say, I will be always on a positive side. I wanted to happen this change, but here I will use this NO as a new opportunity or not possible, because these are the new opportunity which I can learn, I can work with Partha, and I will be definitely very happy to part of this new opportunity which we are going to have. My agenda will be, we'll be trying to understand the India and its diversity, healthcare system in India, the differences in India and UK, and then there are some hidden truths of India too. This is a population of 1.4 billion, and we have 50% of the population which is poor, which holds 2% of the wealth, and that's what we have to feed them. Middle class is a 40% of the population, which is around 11.6 to 23% of the wealth, and we have upper class, and that's what we are saying, that we can afford everything. And I always say that those who are upper class, please make sure they get the best of the best treatment, because they are going to change the lower class tomorrow. That's what we want for us. So disease burden, we have dual burden, and that's very important, because we have a challenge of infections and chronic disease, and I'm sure UK also have many challenges like what cancer care, and the same way we have the challenges of infection too. This is what I told you, the poverty, 50% of population in need, they need for food security bill is there, and they are given free food. So forget about getting money from them, if you are asking for them the best therapy, the next question will be, what about my evening food? That's what we have the challenges. The healthcare system is also, we have primary care to tertiary care, and this is the public health system. This is from primary healthcare center, community, sub-district hospital, district hospital, and medical college. We have primary care to tertiary level, and Indian healthcare system is focused on system built to tackle communicable disease. So our system is to build, extinguish fire, not to maintain furnaces, and that's very truth of India at present. If I go to medical college, you'll be surprised, there is no dedicated type 1 clinic, even in the endocrine department across the country. More than 50 tertiary care hospital in India are having a DM endocrine program, but they don't have dedicated type 1 clinic, and that's what the truth is. Chronic lifelong condition like type 1 diabetes is less integrated in a public health That's again important aspect. Public health and PSC are structured for one-time medical response, not for chronic conditions. Most government health programs are focused on a high mortality and a high incidence illness. And that's what our government focus is. Like tomorrow, if you go and talk to them, they will be talking about the malnutrition, diarrhea, pneumonia. These are the common problems they have. We have huge ecosystem. Even trained endocrinologists are prescribing non-specific prescription, and this is truth. I'm going to show you one of the prescription, but this is not because even there is no dedicated type 1 clinic. They just want to prescribe therapy, nobody is going to review them. And we have all other alternative systems also, which are equally popular in our country, which is Ayurveda, Yoga, Unani, everything, which are also practicing allopathy without even any permission. This is one of the prescription by a trained endocrinologist. I am seeing you in 29 July. This guy is at 25 years with a 10 years of diabetes. Even he might not have done any investigation for this person to confirm the diagnosis of type 1. But can you think of someone with a weight of 43.75 kg with a 10 years of diabetes history, with a 45 kg man in a 25-year-old person, has to be type 1. And this is what the prescription is showing, 3070 by a trained endocrinologist, with a glimicin, which is a glimipride, with a telnipride, and with voglibose. You can see here all other anti-diabetic medication. Now the point is, if someone like a trained person writing this prescription, what will write the primary care physician? They have to learn from these people, and they will be writing again and again the same prescription. Let's take a closer look difference between India and United Kingdom. We have a large population. I need not to talk that. We know that India can be compared, or the West Bengal can be compared with UK. But this is what the GDP, India, and per person GDP is what you can see. Nominal terms, UK per capita income is 20 times higher than India's. And if I just take the inflation part, the adjusting cost of living, UK still leads by 5 times, and that's what the GDP or a per person is, like 5 times more than that. India government is spending on health is less, both in absolute and relative terms. UK by contrast has a tax funded NHS. I always say, someone asked me that why in India government is not providing free pump to anybody. We had gone, India can provide now, when we can have 1 bullet train, now 10 bullet trains we are going to have, and 1 bullet train is costing more than 2 lakh crore, which is going to cost for 1 bullet train, and we are going to have another 10 in next 5 years. With 1 bullet train, the cost, we can provide everyone, all type 1 in India, the best of the best therapy. So not possible, is it? But only thing is the government has to do it. The total health expenditure is only 3 to 3.3%. By public funding is 1 to 1.4%, with per capita spending nearly only $74. While UK, this is 10% of their GDP, with public funding is 8.7, and per capita spend is $3,500. So you can compare US 74 versus 3,500. That's what we have. The financing gap is UK healthcare spending 9, while India healthcare spending 1.9, and this dramatic difference in healthcare funding creates a fundamental constraint on what policy can realistically be implemented regardless of that design. So whatever I design, we have to go to the public place and we have to ask them to make the policy, and they will say that we don't have that much budget. This is what the UK priority. They have cancer, cardiovascular disease, and diabetes, while India reality is still, we are struggling for tuberculosis-free India. We are struggling, we want that malaria, dengue, diarrhea, rabies, other infections, malnutrition, and we are midday meal program are one of the biggest, for the children. We are providing them midday meal. We are not providing them insulin, but we are providing them midday meal because they don't have, neither they take breakfast nor they can have afford to go and have dinner also. These are some of the hidden truth. We have Ayushman Bharat, one of the biggest, I can say even bigger than any other or UK health policy. This Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, is a landmark health insurance. So everybody in India with 500,000 rupees, they are insured, and they can be providing free tertiary care, not only in the government setup, they can go in even in a private setup. The surgery, you cannot think of even in UK to get someone angiography, bypass, angioplasty, knee replacement, stroke management, everything is free up to that money. But the problem when it comes, what they are saying, for any acute problem we are ready to pay. For any chronic system management, we don't have the system. And that's what the biggest challenge is. It's not that India government is not looking for it, and we are talking to them multiple times. Since last, he knows that, and he's part of many of our meetings, and this is what we are doing. Ayushman Bharat, why it is? Because they are thinking it's a chronic care basis. I think India is not geared up. We are still for the acute problem. Visibility of impact, we have policy gaps, supply chain, limited awareness. This is what the ICMR guideline, and I was the only one who stood against all those people who become part of the ICMR guideline. They had asked me to become the part of ICMR guideline for type 1 diabetes. I told no, because they asked only 2 times is sugar to be checked in a person with type 1 diabetes. This is the national government guideline. I told I will not be the part of it. This cannot be. How it is possible that you ask from the government of India, ICMR is making the guideline for a type 1 only to get 2 times the sugar. For the guideline, they have to check at least 5 times, 6 times, 4 times. How they can have that sort of a ICMR guideline? The private-public partnership is yes. We private doctors, when we go to the public hospital or when we wanted to go and government talk, health department, finances, hospital admission, this is what each state, it is like each state is responsible for their health. It is not the nationally we can think of making policy, but still, like in Kolkata, my good friend Sujoy had done, we are struggling. I could convince health minister, we have the budget which is already allocated, 11 crore per annum from last 3 years, and this is what we are meeting with health minister, we are meeting with health commissioner in Gujarat. They have the money, but they don't know what to do, because one thing is Dr. Sujoy is working with a government hospital, he's a professor, and when they see me, I am a private practitioner. They have first thing they will be asking, why you are so much interested to improve the public hospital care, why you are interested for that, and still efforts continue. These are the pediatric disorder, and when I go and invite the people from professor of pediatric, a private pediatrician, a pediatric endocrinologist, a pediatric neurologist, a neurologist will come and say that, see, these many people have epilepsy, what you are doing for them? What about the neurodevelopment delay, which is much more than type 1 diabetes? Psychiatric disorder in pediatric age, disabilities, these are the absolute number in India with 3 million. I have less than 200,000 people who are actually type 1 in India with the incidence, and 3 million children have absolute disability. What we have, pediatric disorder. Prevalence comparison always show this is a low population disease. Policy maker focus on disorder which higher prevalence, and shifting the national focus or budget significantly for type 1 diabetes may seem disproportionate to public health planners. These are the other challenges. We have multiple stakeholders. I talked about a Rashtriya Yojana, the next, but there is a Rashtriya Bal Swasthya Karyakram. Even that 11 crore rupees had gone to Rashtriya Bal Swasthya Karyakram of Gujarat instead of giving it for type 1, which health minister announced it. Still evolving health technology assessment ecosystem. This we are producing a paper with the Public Health Foundation of India and talking that this is what the HTA is. That if you are going to give the technology to these people, I am sure they will have a better quality of life, a longer life, and they will make the changes. This is what we are doing. The dilemma is for children and families with type 1, lifelong burden is immense and unique, but national priorities are guided by immediate population level impact. The government is looking that what is the immediate impact is there. They are politicians, they are looking for their votes. What can be changed for that? That requires careful advocacy to elevate chronic illness without minimizing broader system challenges. Advocacy, there are multiple gaps. I don't go and ask the government now provide 4 times insulin. That they are already getting. I go and ask them to provide the CGM. I go and ask them to get the best of the best system AID. Why can't we have the best system in India? And that's what available is at least, and all the private practitioners, all pediatricians, anywhere if I go and I talk about the best therapy which is available, but there is a lack of public insurance coverage for diabetes technology. So implementing UK like type 1 diabetes policy in India is not a cakewalk. It's rather a cake fall, because our children deserve a policy which is backed for India, not imported from London. That is what we feel. The way forward is goal. Ensure a very equitable, accessible, and a very high quality care for all children and adults with type 1 diabetes in our country. We have come a long way in type 1 diabetes. What gives us the hope. So I don't say that we are not come in a long way. As Partha had already said that from 2008 I am working. I was when part of advisory council for SPAD. They were surprised that why you are here. You are an adult physician. What you are doing for type 1? And then I asked, no, I want a meeting in SPAD. The first time SPAD never had gone to any developing countries. It was only in India in 2018. And we changed the scenario in India. Till that picture abhi baki hai mere dost. Our type 1 diabetes care in India will definitely improve. We need your help. We need your, all the time, your support. And still, story is still unfolding. Integration with ABHA and healthcare program. This will help build a lifetime care system and prevent children from being lost in the system. This is what the ABHA program, which is launched by Government of India. It is like each and every child data where you put it, even for the private practitioner, they pay from the ABHA, the Government of India. Community health worker empowerment, mobile support. We have our own WhatsApp chatbot, multiple languages. Our type 1 foundations, they are working very hard, low cost. A tech-enable last mile ecosystem, so no child with type 1 diabetes left behind. That is what our vision is. We are looking for a national type 1 diabetes registry, integrating type 1 in existing health programs in states, financial and insurance integration, foster research and invest in health technology, and implementing school and community-based technological solution. So let us say no, it's not, it's new opportunity. I'm not here debating against Partha. Partha is part of our system. He is what we have to work together. That's what we are looking for. We want new opportunity to improve the care for type 1 in our country, opportunity to innovate, integrate and inspire, opportunities to ensure that every child with type 1 diabetes in India has same right to life, health and hope as anywhere else in the world, maybe UK or even any Western world, US or Canada, anywhere. So India must design its own type 1 diabetes policy. The recipe, affordable, inclusive, digital first, not copy paste from any, whether it's a NHS or, as already Partha said, that's not great. We are looking for our own. Implementing UK-like health policies in India is not a cakewalk. It's like a trying and wearing someone else's tailored suit. It may look elegant because it's UK, but it won't fit. India needs its own design, its own fabric, stitched for its own people. India is also the land of frugal innovation, digital revolution, and resilient families. With this, love the phrase of Dr. Partha, roses are red, violets are blue, till then supports will do. My version is roses may be red, violets blue, but until the system grows through and through, smart support, local care and compassion will do. Jai Hind, thank you very much.
I will invite Dr. Partha for rebuttal, and rebuttal will be for 2 minutes only.
To start with, there is a very important slogan in India as regards diabetes care. You know what the slogan is? Banshi hai to mumkin hai. I think Banshi has already described to you. I'm not going to do much to it. We both agree that there's work to be done, but we can definitely do it. But I'm going to say one or two quick things, which is, first of all, it's about the challenges, but Banshi has also outlined in the last 2 or 3 slides what's also coming, right? And cakewalk is always a term. Nothing is a cakewalk, nothing. You know, even if you take, let's say, the most important health program in India, it is never going to be a cakewalk, however much focus in it, because of the diversity India has and everything else there. So all I will say is that it is never anything is a cakewalk, but you have to believe that it can be done. Since we have used a lot of Shah Rukh Khan quotes, I think we need to switch now to Salman. As before that. And the only quote I would say, tension nahi lene ka, khali government ko dene ka, so that they can make type 1 diabetes as a focus, just like they have for everything else. So thank you very much for everybody for listening, and always a pleasure to share the stage with Banshi.
Thank you. So, thank you, Partha. And we were not having any debate. We wanted to learn what we can do for India. We are really changing, and I'm sure in coming years, the Partha will be also proud. He will have a proud feeling that he could change India. He's already doing a lot of work, a lot of changes, and we are working together to really make changes in India, which is possible. And we all believe that India will be in next 5 to 10 years. What I am looking for 2047, when India will have 100 years of independence celebration, we will be developed country. We will have the best of the best technology available, and all our type 1 will have a normal life. What he had shown the changes in 5 years. Before 5 years, this data was published in our RSSDI in 2019, and then he had shown in 2025 how we have changed. Probably in next 5 years, we will show the change that our people with type 1 diabetes, they have almost normal life what they have in Western world. Thank you.
So thank you, both the stalwarts. I think with the support and guidance of Dr. Partha and leadership of Dr. Bansi, we will implement and adapt UK-like health policies in our country, and we will make type 1 diabetes care like the standard of care which is there in the global countries.
Thank you.
Thank you. Thank you, everyone.
You wanted a vote? Oh, they want a vote. Evidently, there's a vote as well. Simon wants to say something.
This debate should continue, because you haven't addressed some really important things. And is this working? Yeah.
Yes.
So, the first thing, I've had the honor of coming to this country for many years, and I'm asked to talk on hypoglycemia, which is fine, and technology. When I talk about hypoglycemia, I said the most important cost-effective thing you can do is teach people with diabetes type 1 to manage their condition themselves. And Indian doctors, with great respect, endocrinologists who I admire, they know about endocrinology, I only know about diabetes. But they like to be in charge, mostly men probably, but women as well. They like to be the boss and tell people what to do. That's how they've been trained. And it's a cultural barrier to the management of type 1 diabetes, in my opinion. A person who has to manage type 1 diabetes, and even doctors in India say, oh yes, it's the patient. They don't believe it. They like to be in charge. And I can go back, because I'm very old, 30 years to where the situation was in Britain, and in the 80s and 90s, the standard of care was terrible, and I was a part of that. I worked with a guy called Robert Tattersall, who realized that the person with diabetes has to do this, and you haven't adopted that system. You're still behaving as endocrinologists who are very smart and who are in charge. There is, the father of type 1 diabetes is a guy called Professor Michael Berger. Has anybody heard of Professor Michael Berger? Okay, vaguely. He, in 1981, when blood glucose monitoring came in, realized with his wife that blood glucose monitoring would be given to patients for them to be in charge and manage their diabetes themselves. And he developed an insulin and treatment program, revolutionized the management, and made the patient independent of their doctor because they chose the insulin doses because they were trained to do so. And in the 1990s, Sue Roberts, very well-known person who changed diabetes, she was the forerunner of Partha in taking a national role. And she and I and a friend and colleague, Stephanie Amiel, went to Germany and learned to give the skills type 1 diabetes to the person and their family. And we developed a training program based on the German model. It's all German. And we called it DAPHNE, Dose Adjustment for Normal Eating. And if I told you about a technology which could reduce hypoglycemia by 80%, I think you'd want to use it. If I told you about a technology that could reduce diabetic ketoacidosis by 70%, I think you want to use it. And yet when I give a talk about that here, nobody's interested. £300 for each individual for life. It's incredibly cost effective, strongly recommended by NICE, RHDA, and it's a one-off treatment. And yet, it isn't done here. And Banshee, you gave a superb talk. I never heard anybody talk so fast and say so many important things in 5 minutes. But you didn't mention education. And I don't think we should call it education. We should call it training. You should train people with diabetes to manage their own condition. And it's only a step, but it would make a huge step. And it should be implemented. Okay. Initially by those fantastic people I heard, but then it could be spread around the country. And I offer you people to come to the UK and take that, translate it into all the different languages and run it. And it will be the first step to really make a difference. It's not a cakewalk. What with Julian Chan says, to really make a difference, you'd have to take the first step. It's one of the first steps.
Thank you, Simon. We definitely are working on that, so that, as I said, we'll pick up with that on you on the Daphne thing as well. But thank you for your kind words. Much appreciated regarding the education side as well. Thank you.
Thank you, sir, for your comment. I think we conclude our session here.
So Partha is winning. Everyone should hands up for Partha, because if Partha is winning, we are winning. India is winning. It means that we are winning here. We want everyone in India to improve their type 1 diabetes care. With this, I thank. And Doctor, I talked about the education because I talked about the tertiary care hospitals where the endocrinologists are trained and where the type 1 care is suboptimal. That may be the one of the reasons that education is not up to the mark. But with this, I end and thank you once again, Partha. And thanks, Pratap and Manoj. Thank you.
Right, one little thing that we have to do, right? So today in the audience, we have somebody with type 1 diabetes who's also that person's birthday. So Rekha, on behalf of all of us, we would like to wish you a happy birthday, and please come along and we will wish you on this lovely day so that we can recognize this for you as well. Very good. Who said that? Type 1 is a cakewalk.
So after this wonderful session, it's now time to dive into the session of Diabetes Pearl, for which I would like to invite our esteemed chairperson, Dr. Lotika Purohit from Mumbai and Dr. Aarti Ullal from Mumbai.
Good morning. So we start into the session. The first speaker today is Dr. Vipul Chavda, setting up a diabetes clinic. Because this is something which is a very challenging topic, especially after hearing such a fantastic debate on type 1. I hand over to Dr. Vipul. He's an endocrinologist from Ahmedabad, chairman and founder of Rudraksh Institute of Medical Sciences.
Thank you so much, Totika ma'am, for introduction. Thank you so much, Dr. Purvi ma'am and Dr. Manoj sir, for allowing me to talk on this topic. And as Bansi sir said, until the policies are made, we have to get the work with our compassion and our local work. So as an individual doctor, how we can make difference in our practice and how we can help our country, that we will going to discuss in next 15 minutes. Policies will be made by government, that is not in our hand, but how to run our clinic, that is in our hand. What we should do in our clinic, rather than being a Rajnikant or solo warrior, we have to make a system that will help to grow health in our patient system. We have to understand why, how, what, who, which, when and where. First of all, why there is a need of diabetes clinic or obesity clinic. Yes, we all are accepting that obesity is epidemic and exploding. In most of the talk today and yesterday, we are talking about obesity. But what OPD setup we are having, it lacks structure. For obesity, for diabetes, we need a structure which is a holistic, and we can provide nutritional care, exercise care, counseling, sleep consultation, sexual well-being, everything must be there. So my mentor, Dr. Bansi sir, once said me that you don't need to treat diabetes, you have to live diabetes, and that's how you can make difference in a person living with diabetes. Because in diabetes care and obesity care, at the clinic level, it is important, but also there are so many stakeholders like government level, institute level, community level, at technology level, at provider level, that all have to be considered in your clinic to provide a better health to your patient. Complications of obesity, we all know that there are mechanical, metabolic and mental complications starting from pain, arthritis, breathlessness, obstructive sleep apnea and obstetric problems. There are metabolic problems like type 2 diabetes, vascular disease, MASLD, PCOS, infertility and hormone dependent cancers. Again, there are mental issues that are very rarely addressed in most of the clinic like depression, anxiety, low income and body image dysphoria. So many health consequences often present in the same individual when they are suffering from obesity. You will be surprised that more than 200 diseases, including functional disorders, cancers, and negative social consequences and stigma are associated with obesity. And that's why we have to treat obesity in a proper way. What should be our mission? Our mission should be harmonized care for effective healthcare service delivery to get optimized outcome in friends with diabetes, obesity, and metabolic disease across the world. How we can do it? We must understand that diabetes treatment is not a single doctor's task. It cannot be done by one person. Yes, doctors are primarily important in that, but we also have to have specialists in our team like kidney, eye, neuro, and cardio. You have to have proper nursing care. Nutritionist must be in your team. You have to provide exercise facility, counselor, educator, patient support group, medical insurance, telemedicine facility, technology and devices, pharmacy and pathology. This all must be a part of your team. But as a doctor, you have to understand most of the time what we lack is cash. Being Gujarati, being Gujju, I have to talk about cash. What is cash? Cash is a knowledge, attitude, skill and a habit. First of all, you have to develop a knowledge about obesity. When you are treating obesity, you must understand every aspect of obesity, how it is, the pathophysiology is, and how we can treat it. Then you have to maintain the attitude. Most of the time, we are seeing more than 60 to 70% of our diabetic population are obese, but we do not have time or we do not have attitude to address that challenges. So first of all, we have to develop the attitude that we are going to treat obesity. Then we have to develop skill. In multiple programs like SCOPE, like ICO, like in DRS, like in DIAOBECON, we are programming many projects to train doctor on treating obesity, and ultimately it's your habit. If you are just prescribing medicine and thinking that the disease will be taken care of by medicine, you are wrong. You have to develop habit for holistic care in your patient. Also, we have to understand diabetes and obesity is a lifelong disease. So you have to provide holistic lifelong health for all the metabolic disease. Second, we have to add values, because Bansi sir already said that there are so many stakeholders in treatment of diabetes and obesity. We have to make them understand the value of adding value in that program. Third is a collaboration, research and infrastructure. Then real-time research and aggregation, these all are very important part of your treatment. Then let us understand how stepwise we can make a successful obesity clinic. First, as I already mentioned, you have to develop a knowledge, educate in obesity management. Then decide your obesity practice model, that you are going to treat all the disease along with obesity, or you are going to treat only obesity in your clinic. That you have to decide. After deciding that, you have to start your clinic and then develop obesity management plan for your patients. Then you have to involve a continuous improvement and innovation. You have to evaluate, improve, and ultimately from pre-clinic you can reach up to the standard of care. This is a very well-known pyramid that says that from pre-clinic how you can develop your center of excellence. Let's go through that. First is a pre-clinical stage in which you have decided that you are going to treat your patient with obesity. Here there is no specific equipments are required, just required is your mindset. But once you decide that you will going to have a standard clinic in your practice, you have a clear program with goal setting and follow-up of using patient's assessment tool. You have to have some instrument like 200 kg scale, large blood pressure cuffs, appropriate chairs, appropriate examination tables and gowns for the patient, and at least you have to dedicate 20% of your time in treating this obese patient. Then if you are willing to plan an advanced obesity clinic, what you have to do is you have to develop a different treatment policies, like you have to have bariatric surgeons, psychiatrists, patient support group and other relevant supplements specialists in your team, and you have to have more than 200 kg beds, ramps, stadiometer, accessible toilets and wide doors for this patient. And ultimately, if you are going to plan your obesity clinic as a center of excellence, you have to have a full-fledged lab backup, full-fledged diagnostic backup, you have BCA machine, you have DEXA scan, and ultimately you are training other people near your vicinity for the management of obesity in better way. But just starting clinic is not sufficient. You have to think beyond the prescription, you have to think about the system. Because once you open your clinic, you are not running your clinic, but most of the time your clinic is running you. This is very common scenario that in the evening your receptionist will come and tell you that there are 30 patients waiting, there are 10 pharma people waiting for you, but you have to attend a social meeting in the evening and then you are stuck. So what we can do to overcome this thing, and we have to develop a system. And first step to develop the system is delegate. The central message of this slide is delegate. But doctors are often skeptical to delegate because they are fearful. They are fearful of misinterpret, they are fearful of doing mistake, or they are fearful that their staff will misinterpret the report. But we have to understand we can delegate without losing control. You have to identify proper staff, you have to train them, you have to monitor them, and again if they are making mistake, you have to improve them. So let's understand how to delegate without losing control. You need not to see all the blood reports. You can train your educator to see all the reports and make them green, orange or red. If they require attention, they will do a red alert and you will attend the report immediately. Education, you are not responsible for educating each and every patient. You have to have team. Your diabetic educator or your nurse will take care of the training part. You cannot make reel at 11:30 p.m. when your family is waiting for your dinner. You have to have some freelancer or good advertising agency who can manage your social media. It is a common scenario that in the clinic when you are seeing patient and your staff will come and say that there is no ink in the cartridge, the lancet are out of stock. That should not be happen. You have to have a proper supply chain in your clinic, and ultimately your receptionist is a very important public relation officer for you. For each and every patient going out of your clinic, your receptionist once again meet them and take feedback for them. Second important step is HR policy. Like no country is without constitution, there should be no clinic without HR policy. I am going to tell only 12 basic HR policy that you need to have in your clinic. Yes, I think you will think that it is difficult to implement all of them, but don't do everything at one time. Take one policy, implement it for 1 month, second month take second policy. So at least in a 12 month you can implement all 12 policies. Like your clinic is not your horoscope that today will be a bad day. Like your staff will call and tell I am not coming today, or I will be on leave from tomorrow, or I will not come from next month. It should not be there. That should be a proper leave policy. Always a good staff require appraisal. So there should be appraisal system, ethical training should be them, attention tracking, code of conduct. They cannot share any patient's reports on social media, or they cannot talk about any patient's report during chai break. Also, a good dressing will increase confidence of patient on your system. Confidentiality should be there. Grievance redressal should be there. Digital device policy, what should be email, what should be WhatsApp, and what should be called. They should know. Communication protocol should be there. And disciplinary process, if they mistake, they will be educated. But if they do some fumble, they will be punished. And ultimately, all the staff who are existing for your system, they also should be interviewed properly. Last two slides, we need a clear reporting system. We don't need a chaos, we need a clarity. So we need to have a reporting system. Like in our clinic, every Monday, our staff will come and report 3 metrics. How many numbers of follow-up calls they have done, how many patients they have educated, and whenever there is red flag like hypo or non-compliant, they will report us immediately. So this kind of dashboard should be there. That should not be any drama. And last but not least, the most important thing is marketing. The missing pillar in the most of the clinic. Even the base clinic won't grow if no one is knowing about them. How we can do ethical marketing, how we can do smart marketing. There are multiple steps like local visibility, digital presence, doctor branding, referral network, community engagement. For local visibility, you can have health talk in your area, you can have poster in nearby labs and pharmacies, and you can have WhatsApp update. For digital presence, you can have Google business profile, you can upload on social media, you can upload your video, reels, or even patient's testimonial. Doctor branding, speak at multiple CMEs, attend health camps in your vicinity, and also make a friend with your general practitioner to build a referral network. You also have to meet the specialists, dietitian, pharmacists, even dentists can refer you the diabetes and obesity patient. And ultimately, last is community engagement. Celebrate many days like World Obesity Day, Diabetes Day, and also organize CME and some celebration to those patients who have achieved like HbA1c hero and obesity hero like we had yesterday in our inauguration ceremony. Thank you so much.
Dr. Chawda for that very practical approach to set a diabetic clinic.
Thank you, ma'am.
Take questions at the end of the session. Moving on to our next lecture, we have Dr. Amit Rajput from Jalgaon. He's one of the pioneers who set up the first diabetic clinic in Jalgaon and has his own fetal hospital. He'll be talking to us about diabetes, aging and longevity today.
Thank you. At the outset, I would like to ask you, what is the average life expectancy of Indians? Any idea? Yeah, around 70 years. It is still 10 years less than the advanced nations like Japan, Korea, some countries in Europe and Americas. Any idea what was the life expectancy of our grandfather, their grandfather, their grandfather? 110? 100? 90? Okay, so when the British left India, the life expectancy was, I think, 37, right? And if you trace every year or every decade back, it was even lesser. So what improved? Sanitation, hygiene, vaccinations, medical advances, NCDs detection and treatment, amongst various factors. So with the increasing age, there are other issues like NCDs. So aging, it's a complicated definition, but just to cut it short, it is telomere shortening, there is inflammation, and there is mitochondrial dysfunction. So the big physiological function one has between 20 to 30 years of age. There is good muscle mass, the VO2 max is good, bone density is at its peak. But the first measurable cellular aging signs are seen within the year of 30 to 35. There is DNA methylation changes, there is telomere shortening. After, in the 40s, there is sarcopenia, reduced basal metabolic rate, neurovascular changes. And after the age of 60, you can see immune system weakening, cognitive slowing, and frailty. You may be able to brisk walk, you may be able to jog, but you cannot sprint after the age of 30 or 35 unless you actually train for it. So everything is driven by the fat, the deposition of fat at abnormal places in most of the organs, especially intracellularly. You are what you eat. So your stomach size is this much, around the size of 2 fists. तो इसमें हमको क्या भरना है? इतना ब्रेकफास्ट, इतना सारा लंच, इतना सारा डिनर. So you are supposed to fill your stomach with healthier options like this and more protein, but ये तो ब्लांड होता है, इसको टेस्टी बनाने के लिए क्या करना है? बहुत मसाले डालने हैं. So make it so spicy that you cannot eat it directly. So you have to dilute it with, right, chapati. Chapati तो dry रहता है, तो उस पर क्या लगाना है? Ghee. Very good. So ultimately, the health conscious people, they use oil very sparingly, ideally in drops, but most of the Indians fail to do it. Salt intake should ideally be 3 to 5 grams, but many have it 10 to 15 grams per day. So all these factors ultimately lead to fatty liver, that is an indirect indicator of obesity. Gut-brain axis is a very complicated thing. It is interplay of many hormones like ghrelin, leptin, you all know it. There is also interplay of many neurotransmitter in the brain, but to make it simple, there is hypothalamus. It is a switchboard, like when fuel is low, it makes you hungry. When full, it should signal stop. So hunger and satiety center are in the hypothalamus. But that was the old hypothesis. Now newer areas of the brains are discovered, like amygdala, that sometimes we don't eat because we are hungry, but because we are sad, stressed, or bored. That emotional part of the brain pushes us to eat for comfort. Then there is nucleus accumbens. It's that part of the brain that lights up when you see pizza, sweets, or fried snacks. It makes food exciting and rewarding. So in a person who struggles to lose weight, nucleus accumbens and amygdala are dominant. But there is also an area called prefrontal cortex. This is the thinking part of the brain. The one that says, I know you want that cake, but I don't actually need it. It's your inner referee. So if you want to lose weight, you need to strengthen your prefrontal cortex. You can do it by increasing protein intake in your food, strength training, and by practicing small habits like pausing, eating mindfully, and planning your meals. You strengthen your prefrontal cortex. And over the time, your cravings will still come, but you will be in the charge and not them. So obesity is normal response of the body to abnormal environment. Have you ever used ChatGPT? सिर्फ एक फोटो लेना है, अपलोड करना है, it shows the calorie, it shows different content and its calories. Make it a habit. It helps in big way. Sleep. 1/3 of our lifetime we are supposed to sleep. Again, 1/3 of our lifetime we are supposed to sleep. Wakefulness is lower level brain damage. It accumulates beta amyloid and tau protein. These are two culprits that underline the Alzheimer's disease cascade. And sleep is your sanitary salvation. So we are supposed to reach this stage 3 and stage 4 every night multiple times. This is where healing occurs. This is where aging slows down. But it takes around 90 minutes to reach that stage. लेकिन क्या होता है, when you reach stage 1, stage 2, stage 3, पार्टनर खर्राटे ले रहा है, पार्टनर लात मार रहा है आपको, मच्छर काट रहा है, कुत्ते भौंक रहे हैं, बच्चा रो रहा है, and so on. So you are not really able to reach stage 3 and stage 4 consistently. Other day, next day you are irritable. This continues for weeks, months, and years. So ideally one should practice sleep hygiene. कितने लोग without alarm उठते हैं? बहुत कम. So ideally you should plan your sleep so that you should wake without alarm. And these are different points which helps in sleep hygiene. Any idea what sleep divorce is? Husband wife, they stay together whole day, but सोते समय they prefer to sleep in a different bedroom, preferably in the same house and preferably alone. You can use filters like Twilight on your app, which helps you sleep faster. Spine health. A person's decline starts with lower back and thigh. The muscle gets weaker, the posture declines, and with age there is cognitive decline, emotional issues, depression, there is severe muscle weakness and bone loss. And one unfortunate day, bathroom में पैर फिसलता है, and then what happens? Hip fracture. So the statistics of hip fracture after the age of 65 are very frightening. 1 in 3 people cannot survive beyond first year. It is worse than even some top cancers. So does the person die of the fracture? No. He dies of weak muscles, weak bone. He cannot move. And then infections catch in, or there is severe issues which causes the mortality. Most of the international flight, सबसे आगे कौन रहते हैं? Indian लोग. Weak muscles, weak bones. I'm not making this up. These are the headlines. So muscle, we lose 1 to 3% lean muscle mass per year after the age of 30. Muscle is your organ of longevity. It is your greatest defense against aging. The grip strength is strong predictor of severe mortality, and yet we treat resistance training as optional. It is not. Walking, the CV benefits start after the 4,000 steps per day, and with each 1,000 steps increment, there is decrease in severe mortality. But is walking enough? Does it challenge your muscles enough? Does it help in balance, upper body strength, bone density, joint stability? No, it is strength training. So, types of exercises, just 2 minutes. This type of exercises, aerobic and strength training. Those who are not familiar with the exercises, you can do them at home. You can take the resistance band. You can stretch them in various positions. You can use ankle weights. You can do heel raises during flossing your teeth, cooking. You can do wall push-ups. You can do chair squats without taking support of your arms. You can do farmer's walk. First you start with 5 kg, walk for 1 minute, then 10 kg, then 15 kg. It strengthens your core. And if one can afford, or if it is practically feasible, you can join the gym to challenge your various muscles. By the way, this is my mother who started her fitness journey at the age of 72. Now she's 75. But after 2 weeks, it is very difficult to find your consistency. So you must find your own why. So, for example, my why is playing badminton. I do fitness for playing badminton. Someone does it for dance. Someone does it for looking good. So you must find your why. You should avoid prolonged sitting. You should take steps instead of escalator. You should walk during talking on phone. The common excuse is you don't have time, but you can have 100 problems in life until you have a health problem, and then you only have one. If it doesn't motivate you enough, exercise also improves sexual health, cognitive health, and cardiovascular health. You should address your mental health. It is important to seek help from professionals as and when required. These are blue zones where people, last 2 slides. These are blue zones where people live more than 100 years. These are their common characteristics. They eat unprocessed diet, good sleep, they move around throughout the day, they stay social, they have family values. इसमें कुछ different नहीं है, हम जो करते हैं वही है, but हमको इसके लिए efforts लेना पड़ता है. This is imbibed in their culture. As a diabetologist, this is probably my greatest achievement. I have been able to inspire my twin daughters to play badminton. My wife, she is into fitness, and these are my mother-in-law and mother at the age of 65 and 75. I guess they are fit enough. So the key takeaways are, your genes are your predisposition, but they are not your fate. Your lifestyle decides whether a particular disease would express itself or not. Every gram of protein you don't eat is the additional gram of carbohydrate and fat you consume. You should learn the art of cooking in less oil and less salt and develop taste for it. A night's good, uninterrupted sleep is the best thing you can give to your own body. Movement is medicine. Prolonged sitting is a disease. Exercise has benefits, but if you have to exercise to keep your weight down, your diet probably is wrong. Exercise must be the part of your personal hygiene. Health is muscle, but you must find your why. Quality of life after 35 depends on your today's choices. So your body does not give a damn about your diet or gym routine if you're constantly overwhelmed by your life circumstances. So you must prioritize your mental health and mental peace. And there are two pains in life. One is the pain of discipline and other is the pain of regret. You must choose either. And you often say you'd die for your family, but would you get healthy for them? Thank you.
Thank you, Amit, for an excellent talk. I think it is, and it had a live example which you and your family have been following. And I think a lot of take-home messages for everybody from this talk.
Thank
We'll
you.
take any questions a little later in the session.
Thank you.
Aarti, you can invite our next.
Yeah. To move to our next topic, which is 5 questions for optimal CKD care in type 2 diabetes, we have with us Dr. P.G. Talwalkar, a teacher, a professor, a mentor to many of us. He's been practicing since many years and has many publications and books that he has authored. To you, sir. Thank you.
Thank you for nice introduction. Can I get my presentation here, please?
केबल हिल गया था सर
Full screen view दिखाओ.
हाँ एक सेकंड I must die here. You want this? मैं पेन ड्राइव में लगा डालता हूँ एक सेकंड सर ओके सर
ये लगाओ.
अच्छा पेन ड्राइव है सर
I'll be talking about CKD and type 2 diabetes. They are usually associated together, all of you know about it. Various surveys done across the length and breadth of our country, including one pan-India survey which we did, longitudinal study, 3,000 patients across the country. About 45 to 50% of the type 2 diabetic patients have chronic renal failure. You call it a comorbidity in some conditions, you call it a complication in some other condition, but the fact that it stays together along with type 2 diabetes. And when both together are there, the macro and microvascular complications, including the renal complication, go down the line in very rapid manner, reducing the longevity, and more important than the reducing the longevity is the reducing the quality of life, which we don't want. So our idea is, in a type 2 diabetic patient, we have to prevent CKD as far as possible. Obviously, we can't prevent in everybody. In that case, we have to detect it in those who already have as early as possible. And once we have diagnosed CKD, we have to treat it aggressively so that it doesn't progress and it doesn't produce long-term complications or to slow down the long-term complications. As 90% of patients in our country are treated by family physicians, they have certain questions because of which, or certain misunderstandings, because of which they are not able to do the optimal use of very effective drugs like SGLT2 inhibitors and other drugs which are now available in a day-to-day practice. They have a lot of questions in their mind. So today I am going to solve these questions. The questions are, is it essential to assess albuminuria and eGFR in all the settings? What are the possible trajectories and implications of renal functions in diabetes, decline in renal functions in diabetes? What is the optimum point of intervention with SGLT2 inhibitors in the progressive course of chronic renal disease? How should stewardship be optimized for SGLT2 inhibitors used in CKD? How we remove the blocks in their mind, misconception in their mind, and give them the correct information? And what are the guidelines saying? Now let's start with the first question. Is it essential to assess albuminuria as well as eGFR in every person? Now this slide clearly tells you that in patients without prior comorbidities and in patients with prior comorbidities, both albuminuria and declining eGFR are independently associated with higher risk. And the risk is far higher than the other risk factors which you feel are important, like systolic blood pressure, diastolic blood pressure, dyslipidemia. But the risks associated independently with eGFR as well as albuminuria is much higher in those who do not have comorbidities as well as those who have more comorbidities. So obviously both of them are important, both of them represent different aspects of chronic renal failure, and we have to investigate them in every patient. Now, worsening of eGFR as well as albuminuria level represents worsening prognosis of cardiorenal events, hospitalization and death. What all these four squares are telling, that if you study the cardiovascular mortality in type 2 DM with renal impairment, kidney failure and need for renal replacement therapy, heart failure and hospitalization for any cause, you take eGFR which is mildly low, almost normal. But even in all those patients with mildly low or almost normal eGFR, as albuminuria increases, the risk increases for all these factors. Similarly, if you have normoalbuminuria in all a cohort of patients, but in different patients have different deteriorating renal functions as assessed by eGFR, as the eGFR reduces, the risk increases. So both of them are again independently important. Now CKD is defined as abnormalities of kidney structure or function present for minimum of 3 months. This is very important. One abnormal albuminuria or abnormal albumin creatinine ratio is not a CKD. Once you get a eGFR of 55, it is not a CKD. It has to be persistent over 3 months, and repeat investigations done after 3 months also should show deteriorated eGFR. You need not have both together. You can have chronic renal failure if there is a persistent albuminuria without reduction in eGFR, and you can have a chronic renal failure with reducing eGFR without albuminuria. So either eGFR is low with normal albuminuria, or albuminuria is high with a normal or mildly affected eGFR. In both the conditions, it is chronic renal failure, but both of them together, obviously the risk is very high. So chronic renal failure is important. It worsens the prognosis, cuts short the life, reduces the quality of life in type 2 diabetes patients, and our job is to prevent it or at least diagnose as early as possible. So we must know, how do we diagnose it? What are the criteria? What are the guidelines? In type 1 diabetes patients, 5 years after the diagnosis of diabetes, which is equivalent to 5 years after the onset of diabetes, because there is hardly any gap between onset and diagnosis, as you know, you should do first screening for renal impairment. But in a type 2 diabetes patient, the first screening should be done immediately after the diagnosis of diabetes, because type 2 diabetes can remain silent up to 5 years. What you will do spot urine ACR, and you will also do eGFR. I told you why we require both. If they are abnormal, look for the temporary causes like fever, excessive exercise, etc., very high blood glucose, etc., etc. Tackle them, repeat it after 3 months, and at the end of 3 months again, if the figures are abnormal, then this is chronic renal failure. What defines CKD? Persistent urine ACR equal to or about 30 mg per gram and or persistent eGFR less than 60. And of course, if there is a structural damage as picked up by imaging technique or a biopsy has been done and it proves that there is a renal damage, this is chronic renal failure. Now let us look at this prototype of man. 50-year-old person, type 2 diabetes, 1 year, long-standing hypertension, long-standing dyslipidemia. You take any parameter for glycemic control, it is poor, he is overweight, his blood pressure is high, his LDL cholesterol is high, he already has UACR 90, which is quite moderately high, serum creatinine borderline. He already has positive treadmill stress test and is currently on metformin, telmisartan, amlodipine, hydrochlorothiazide, atorvastatin, all good drugs. But the main drug is missing to prevent the deterioration, further deterioration in renal function and protect the patient from atherosclerotic cardiovascular disease is missing. Now this man has reduced eGFR and also has moderately increased albuminuria, and both together he has a high risk for further deterioration of renal functions and reaching chronic renal failures, reaching end-stage renal failure stage as well as other cardiovascular complications. So one of them is sufficient to diagnose chronic renal failure, but when both of them are there, the risk increases tremendously as this man is placed as high-risk patient. Next question, what are the possible trajectories and implications of kidney function in decline in type 2 diabetes? There are different ways in which a patient with chronic renal failure in T2DM will progress. One of the commonest ways is trajectory number 1. He will have a persistent albuminuria with slight deterioration over a period of time, and after some time he will have a very rapid deterioration of eGFR and moderately slow progression towards the end stage renal failure. In trajectory 2, regression of albuminuria with treatment, that is also possible. He reduces weight, he controls his blood pressure, he controls his blood glucose, takes proper drugs like SGLT2 inhibitors, last blockers, he can go back to normal albuminuria also. A category 3 is very time seen in our country is a rapid decline in renal function, rapidly declining eGFR and rapidly declining albuminuria state. And category 4 is non-proteinuric DKD with slower decline in eGFR. And that is another reason why you should be consistently measuring both of them. So a given patient may follow any of these processes. Chronic diabetes, long-standing diabetes, or even presence of diabetes itself is associated with greater risk of rapid eGFR decline as compared to those who are non-diabetic, and among diabetic, those who are having diabetes for a shorter time. And more rapid eGFR decline is associated with increased long-term risk of major macrovascular as well as microvascular complication and mortality, as shown in advanced trial. So, and similarly, a rapid eGFR decline also associated with its bad effect on heart failure fund with 3.2 times more common odds for heart failure. So those who are declining, whose eGFR is declining rapidly, will have more macrovascular disease, more microvascular disease, and more heart failure. Now let's go to the third question. What is the optimum point of time for intervention for SGLT2 inhibitors? Now, this is that EMPA-REG trial. EMPA-REG trial was cardiovascular outcome study. The intention was it to get the permission for the product to be launched as per the government of America's rule. 2008, 2009, any new drug coming into the American market has to prove that it is safe for heart. So this study, a very famous study, was done with limited idea of proving safety on heart of EMPA-REG. But when they spent billions of dollars across multiple continents in thousands of patients, naturally they put on some secondary endpoints. And they not only proved safety on the heart front, they proved that it is very effective to protect the heart. But on the secondary endpoints, a very surprising finding was it also showed that 39% relative risk reduction for worsening of nephropathy, 38% relative risk reduction for development of macroalbuminuria, and 46% relative risk reduction for time taken to double the time for chronic renal failure patient. So on the side, they proved that it is very safe and renoprotective. Empagliflozin prevents rapid EGFR decline consistently across and the renoprotective effect was not only seen in those who had a moderate renal failure to start with, it was also seen in those patients who did not have renal failure. Patients with prior microalbuminuria, it was possible to regress to normal urea, no albuminuria, and patients with prior macroalbuminuria regress to either normal albuminuria or microalbuminuria. And just like EMPA-REG, the other cardiovascular outcome studies where primary aim was merely to prove the safety of drugs on heart, they all ended up proving very effective renoprotective effect. Canagliflozin, dapagliflozin, all of them proved. Once this was a very positive, surprising findings, that by that time cardiologists were already saying that this is our drug, we are going to use it as a frontline drug in heart failure and atherosclerotic cardiovascular disease. Nephrologists started thinking about it. Why don't we have a specifically designed renal outcome studies? And EMPA kidney is a specifically designed renal outcome study, just like a DAPA CKD and just like trial done for canagliflozin. Now, what was the difference between these three renal outcome studies? EMPA kidney study, which was the last study to be published, it was published just about 6-7 months back or maybe a little more. It was done, it included patients with lowest eGFR, they went up to 20. It included diabetics as well as non-diabetics, 50% of the patients were non-diabetic renal failure. It included different types of etiologies for renal failure, whereas the other two studies on dapagliflozin and canagliflozin was purely diabetic kidney disease. And the most important thing is, it also included those patients who did not have a significant albuminuria, whereas other studies mandated that the patient should have albuminuria as well as low GFR. So in this study, the empagliflozin significantly proved that it reduces the risk of end-stage kidney disease. And it shows the rate of eGFR decline by half in patients with CKD, again across the different kidney functions. It worked very well in those who had a mild renal impairment as well as in those who had a more significant renal impairment. And if used properly right from the beginning, it can do a lot of wonders, like it may reduce the chances of hemodialysis, prolong the life, chances of other complications, and so on. Now let us go, this is a very important question. A family doctor should remember that when you start SGLT2 inhibitor, you should expect some decline in eGFR up to 30% initially. In first 3 to 6 weeks, it comes back to within 3 months, and then it starts improving. So don't worry if there is a small reduction in eGFR is not associated, there is not indication to stop the products. I'll show you a trial. This is the trial in which those who had initially a bigger drop of eGFR, they had also got an equal protection from those who did not have eGFR. Clinical benefits of empagliflozin significantly outweigh the risk in more frail patients. Another thing is many people are afraid to use it in frail patients. They think that it will have a postural hypotension, he will fall, he will have a fractured neck femur, and so many other things. But if you select them properly, you prevent their dehydration, you stabilize their blood pressure, reduce the diuretics, the trials have shown that they get more benefits as compared to the non-frail patients in the management of CKD and other complications. Incidence of urinary tract infection and fungal infection. Yes, it is a little bit more common. Yes, it is much more, even more common in females than in males. Yes, it is even more common in sultry atmosphere of Mumbai. But that doesn't mean we should not try this drug. If taken care, if you have a proper hygiene, you can use it in many of the patients. Where to stop? I'll straight away go to this slide. Mild bacteriuria without any symptom is not a contraindication for use of SGLT2 inhibitors. Past urinary tract infection is not a contraindication for urinary, just 2 minutes more. Similarly, if if somebody has the urinary tract infection or a fungal infection, you can treat it properly and then restart using it. It doesn't mean that the patient may not be able to use it again. And even in those patients who had some serious side effects, you can always control them and then again try. But there are certain contraindications in which you should not use it. And the last slide I will tell you is SGLT2 inhibitor use, need for CKD monitoring and treatment cessation, importance of restarting SGLT2 inhibitors after planned discontinuation. I think I have already told you, suppose somebody you had to stop it, he had nausea, vomiting, he was having recurrent infections or something, acute infection, you can stop it, settle him. After everything is steady, after he starts eating it, you can restart using it. So, because these drugs provide you so many renal and cardiac benefits in addition to glycemic benefits, blood pressure benefits, you have to try your best to give them to the most of the patient. High risk doesn't mean that you should never use it. You should use it properly. I've tried to give you some guidelines when to use it, but of course there are certain contraindications where you cannot use it. But the time is so short that I can't cover it now. Thank you very much.
Thank you, sir, for an excellent talk. I think most of the questions have been answered regarding CKD. Now we move gears, we move to our next speaker, hypercortisolism and difficult to treat diabetes. For this, we have Dr. Piyush Shah. He is a diabetologist and endocrinologist from Surat. He has a center there, Desai Diabetes and Endocrine Clinic and Advanced Diabetes Center. I invite Dr. Piyush Desai.
Yeah. Thank you. And at the outset, I would like to thank the organizer, Dr. Purvi Chawla and Dr. Manoj Chawla. And this is very important topic. Why? Because we were discussing, Dr. Partha and Dr. Bansi Sabu was debating on suboptimal type 1 diabetes care and suboptimal result in type 1. But though we have number of drugs available with us, now we are talking about diabetes remission with anti-obesity drug, and the scenario is still same, that most of our type 2 diabetic patients are also having suboptimal control. Only 15.7% are having good control of their diabetes. And not only diabetes under uncontrolled diabetes, but they are suffering with multiple comorbidities like hypertension, dyslipidemia, CKD, obesity, CVD, triple combination of type 2 diabetes, dyslipidemia, hypertension or obesity and so on. And that's why we have to think something out of the box where we are coming across uncontrolled diabetic patient. But at the same time, what we have learned in our medicine for years together, that is Cushing syndrome, which is a severe endocrine disorder caused by chronic exposure of excess glucocorticoids, which can be exogenous or endogenous. Exogenous is very common because of unrestricted use of steroid by many a times for indication, without indication, just for pain by a non-allopathic practitioner, that is there. But when we are talking about endogenous Cushing syndrome, it is either ACTH dependent or ACTH independent, and we have to find out so on. But what is important, that in Cushing syndrome, they develop metabolic syndrome and they do develop insulin resistance, which later on leads to impaired glucose tolerance and occurrence of diabetes also. So prevalence of diabetes is almost 50% in Cushing syndrome patient. Now we have in 2016 another data that prevalence of hypercortisolism, not Cushing syndrome per se, but hypercortisolism in type 2 diabetic patient, and which was found to be 3.4%. Proper Cushing syndrome was also there, that Cushing syndrome was almost 1.4%, but hypercortisolism was 3.4%. And then came a very thought-provoking study, that is Catholic study, which is the primary report. Still study is going on for effect of mifepristone on this, but we have data of the first half of the study that 24% of type 2 diabetic patients who are uncontrolled on 2 or more medications having disorder cortisol. which was previously thought to be 3.4% and 10%, and most of the time less than 10%. Here, they have taken comprehensive assessment by lab and adrenal imaging also. Dexamethasone suppression test was also done. Exclusion was also done depending on the previous exposure to steroid. Screening was done by 1 milligram dexamethasone suppression test, and here they have taken type 2 diabetic patient, adult from 18 to 80 years who are on multiple medicine and not yet under control, and what they found that older age significantly increases hypercortisolism. BMI below 30 is independently associated with high odds of hypercortisolism. SGLT2 and GLP-1 were more prevalently used in patients with hypercortisolism, and ethnicity and multiple medication including fibrates and analgesic also increases odds to hypercortisolism. Along with that, we have data that patients with Cushing syndrome, patients with subclinical Cushing syndrome also develop cardiovascular risk. They have more risk for cardiovascular event in comparison to non-Cushing syndrome. Another data were adrenalectomy, which also improves blood pressure and overall metabolic control in patients with subclinical or clinical Cushing syndrome, also improves HbA1c. So we have data now with us that hypercortisolism affects type 2 diabetes occurrence, especially difficult to treat type 2 diabetic patient, and if we find out the cause, if we treat the cause, it may be helpful. So in context of uncontrolled diabetes, hypercortisolism, we have to think in three ways. It can be a comorbidity. As by previous speaker, Dr. Amit was describing that mental health is also very important. Sometimes mental health is also causing. This may be a comorbidity, or this can be a consequence because of multiple metabolic imbalance. This may be part of that metabolic imbalance, or sometimes it can be a cause. So that is what we have to understand. The ominous octet, what Dr. DiFranco has taught us years back, which also having, 7 out of 8 part is affected by hypercortisolism also. Muscle, alpha cell, beta cell, brain, liver, fat cell and gut. So except kidney and that renal glycosuria, all are affected by hypercortisolism. So when to suspect hypercortisolism? When you feel the patient with signs of facial plethora, proximal myopathy, cutaneous stria, bruces, central adiposity, especially the buffalo hump, supraclavicular fullness, acne, hirsutism, paper-thin skin, you may have to think for Cushing syndrome. But these are the patients where you will suspect Cushing syndrome. So in routine type 2 diabetic patient coming to our own clinic, where to suspect and how to screen? Screening is very simple. It is standardized that 1 milligram of dexamethasone suppression test overnight is the best test for screening. Then you can go for late night salivary cortisol or 24-hour unfractionated cortisol. So because there is no single test which will help us to prove Cushing syndrome or hypercortisolism, so you may have to repeat the test. You may have to have at least 2 or 3 tests available with us to diagnose Cushing syndrome or hypercortisolism. But the screening test is dexamethasone suppression test. And if you find out something, then you have to see either it is pituitary or adrenal, and accordingly we may have to go for further imaging and localizing the lesion. That which population you would like to screen for hypercortisolism, difficult to treat diabetes, as we are already discussing, but along with that, patient with resistant hypertension and patient with accidentaloma, or we can say incidentaloma, that we come across adrenal adenoma on routine imaging, either USG or CT scan, you have to analyze patient for hypercortisolism. So this is very important. These are another data which are published in 2021, that patient with type 2 diabetes who are uncontrolled on multiple medicine, 3 to 3.5 times higher chances of having hypercortisolism. You may have to go for plasma ACTH. pituitary MRI, high dose dexamethasone suppression whenever it is indicated, localizing from inferior petrosal sinus sampling is also very important to localize the lesion, and adrenal localizing procedure may be required in form of MRI. Along with that, it is not a cakewalk. We were discussing type 1 management in India is also not a cakewalk, but Cushing syndrome diagnosis or hypercortisolism diagnosis is also not a cakewalk, because physical stress can cause hypercortisolemia. Mental stress like hospitalization, drugs, alcohol abuse, withdrawal, chronic depression, panic disorder may also give rise to higher cortisol level and metabolic abnormalities. So never rely on single cortisol level, and whenever you suspect, go for dexamethasone suppression test, because single cortisol is not going to give you value anyway because of these multiple things. False negative test with dexamethasone suppression test is possible with chronic renal failure and hypometabolism because of liver failure, and false positive test can be due to obesity, stress, alcoholism and psychiatric illness. So if you have some doubtfulness as far as 1 milligram of dexamethasone suppression, always do different kind of tests like 24 hours urinary cortisol or late night cerebral cortisol, because you may need different kind of testing to prove if patient is having hypercortisolism. Now we are discussing this therapy, but do we have, discussing hypercortisolism, but do we have therapy to treat such type of hypercortisolism? We are lacking a very good agent as far as pharmacological agent is concerned. So best thing is like what we do in routine Cushing syndrome patient, that if you find out the lesion, if you localize the lesion, then surgical treatment is the best choice. Followed by maybe radiotherapy is there. As far as medication is concerned, from diabetic point of view, because it acts on alpha cell and hyperglucagonemia, GLP-1 therapy, DPP-1 therapy, and because SGLT2 is not affected by hypercortisolism, these are the better agent to control diabetes. But on the other side, we have pasireotide for pituitary directed agent, if there is pituitary Cushing syndrome, or adrenal directed agent like levoketoconazole, osilodrostate, metadopan, or GR directed agent, that is receptor related agent, that is called mifepristone. And cabergoline reduces insulin resistance, reduces gluconeogenesis. If you remember, bromocriptine was once launched as an anti-diabetic medicine in a quick release formula, though it never got popularized, but cabergoline on similar pathway, having similar better action on insulin resistance. Pasireotide actually worsens insulin resistance and causes diabetes. So pasireotide is to treat Cushing syndrome, not to treat our difficult type 2 diabetes. So just leave it alone. And why all this, why I am talking this topic today is a buzz created by this catalyst report, and the mifepristone is the drug which is going to be already undergoing a clinical trial if it is helping our patient or not, because it reduces insulin resistance. But mifepristone, until unless we have data of this catalyst study, this is something we need FDA approval. It is not a very easy and simple drug like just we use SGLT2 fungal infection हुआ बंद कर दिया वापस या no. It may cause hemodynamic stability, it may cause adrenal insufficiency. So if you are just thinking after my talk that all my uncontrolled diabetic patients should be on mifepristone, no. This is not the time. This is just an indication which may open a new horizon to treat our uncontrolled type 2 diabetic patients. So just to summarize, almost a quarter of patients with type 2 diabetes require 3 or more medication, and though they are remaining not in exactly under control, elevated cortisol activity can exacerbate the pathophysiology of type 2 diabetes and can counter the effect of traditional anti-diabetic medication, making diabetes control challenging. Studies emerging over the last 2 decades suggesting 10% and above patients with uncontrolled type 2 diabetes do have some or more hypercortisolism. Patient treatment resistant with type 2 diabetes should therefore be evaluated for hypercortisolism at least, and may be this will be one of such future where we may apply such type of agent or surgery for our uncontrolled type 2 diabetic patient. Thank you.
Thank you so much for an excellent talk. I would like to invite the speakers on the stage. Then maybe we can have briefly one or two questions.
Is hypercortisolism always associated with hypertension also along with diabetic? Because cortisol is known to have salt
But
restriction.
as I already showed in my third slide only, that hypertension is anyway also very common in type 2 diabetes without hypercortisolism.
Yeah, but it should be mandatorily there.
If patient is requiring 2 or 3 agents for anti-hypertension and 2 or 3 agents for diabetes, then at least you should look for hypercortisolism.
ACTH with serum cortisol level, won't that corroborate for hypercortisolism if you have a normal ACTH with a higher serum cortisol level? Would that not be corroborative to hypercortisolism?
ACTH is helpful, but 1 milligram dexasuppression test overnight OSD is compulsory.
You give 1 milligram in the night and then next day get the
At
serum
10:30 in the night, patient has to take 1 milligram of dexamethasone and then patient has to fast till morning 8 a.m. and 8 a.m. we will go for cortisol level.
Serum cortisol. Fair enough. Thank you.
Yes. See, if one, she is asking that. She is telling that you are suspecting hypercortisolism and now dexamethasone suppression test is negative. Then what to do? Then this can be still a subclinical Cushing patient. So usually after 3 months or 6 months, I would like to repeat this dexamethasone suppression test after 3 to 6 months. Till then we have to manage medically. Because this happens when we are not for hypercortisolism, for Cushing syndrome, when we have strongly suspecting Cushing syndrome, it happens that 1 milligram dexamethasone suppression come negative. So we have to repeat after some time. That is the best thing. And go for, if you are really suspecting, you can go for another testing like late night salivary cortisol, or you can go for 24-hour urinary cortisol.
Let's leave diabetes now. It's out of the session. But I have a patient, a young boy, obese. I am suspicious of Cushing's, but after 1 mg, that is it's lower levels. So that means I should repeat it again because of my suspicion.
See, what happens that when you are suspecting and if dexamethasone suppression test is negative, one thing you consider patient, young patient especially with obesity and mental stress can come to you with severe insulin resistance and same look what you are suspecting in Cushing syndrome. So just treat insulin resistance, just treat patient's mental stress. I think you will not suspect Cushing syndrome or it is very common, especially in young men. No, this testing is for single day, na? This is for single. Yeah, only one. Okay. That is high dose dexamethasone suppression, where we give 4 to 8 milligram of dexamethasone, but usually it is not required. It is 1 milligram. Yes.
Thank you.
Okay. Thank you for an excellent session, and thanks to the audience also for such a nice participation.
So, after this excellent, informative, and interactive session, we move on to our next session, which is on Diabetes India Symposium Emerging Problems. I would like to invite the chairperson, Dr. J. Jayaprakash Sai from Hyderabad, and Dr. Sandeep Rai from Mumbai.
So we are going to start our Diabetes India Symposium, and we have
in all multi-agent intervention chemotherapy is associated with very high chances of severe hyperglycemia. Chemotherapeutic agents themselves can create hyperglycemia in a non-diabetic, or it can unmask diabetes. And that is what you have to keep in mind. This is my paper, which we published at Cancer and Diabetes, which was approved by RSCTI, chapter in medicine. Principle of management: age, weight, culture, eating habits, and associated comorbid condition, compliance, and affordability. So this is my message for how to control diabetes post-operative cases. Since this is an oration, there are no questions normally asked. And after such a lucid trauma, actually there should not be any question. But yet, I am definitely going to answer if there are any queries.
Sir, for a standing ovation for Dr. Anil Boraskar sir. He's a wonderful man, past chair of IDF Southeast Asia, is a patron and fatherly figure for many of us.
I can go to, not in the theater, I don't go, but ICCU and all. And recently, I must tell you that my wife was admitted in Raja ICCU for 18 days. Practically known complication in the textbook of medicine she had. And we call it in Marathi, Divya Khali Andar. Under the house of Dr. Boraskar, his own wife, and only wife, had multiple problems, and thanks to Kunal and our team, she is home and back to normal. Thank you very much.
Thank you, sir, for an excellent conversation and delivering the oration and continuing to support the DRS family. While we endure the memento, I'm going to do one thing which I've been asked not to do. We welcome and receive Dr. Kunal Punamia, the CEO of Raja Hospital, whom I have known for several years now. Kunal came here on one condition, that don't ask me to speak. So I think banta hai ki we have to ask him to speak. Right. So Kunal, it's not a promotion for the hospital. You don't. Raja Hospital is packed. My patients didn't get a bed also 2 days back. So the hospital is doing great. I think just 2 words about what Sir means to the institute and your thoughts on being here.
Good afternoon, everyone. Thanks, Manoj sir, to get this done in spite of me requesting you not to. Boraskar sir has been a guiding force for the hospital, has been here since the inception of the hospital, and has been really involved in the progress. We have something called a Hospital Medical Council. He's been the chair of that council for the last 3 years. Recently, when he said that he would like to pass over the baton to someone else. And I've been here for almost 4 years, and I have seen Sir being really open to what the administration has to say, at the same time being the clinician's voice and maintaining that balance between the clinicians and administration. And he's supportive of us. At the same time, when he feels that something's not really right, would be really open and vocal to us, but not say it in front of people. Come certainly to my office, tell me, guide me what's not right and how I could correct it. So he's been a stellar support for us over there, and today in his oration, he's probably shown it to everyone why he is what he is. And I thank you, sir, for being there for the hospital, for the entire community. and I hope you continuing doing what you do best, and please stop talking about hanging your boots. It doesn't suit you.
Let me also take one thing that before Kunal joined, hospital 200 beds, there were 100 beds occupied. Now today there are 225 beds. To get a bed in Raja Hospital, you have to virtually beg to Kunal ki boss, kaisa bhi karo, ek bed khali karo. There is no bed available in any place.
Thank you, and thank you for being here, and you speak well. So you should continue to speak at such forums, Kunal, and thank you for being here. Let me ask Dr. Kunal to offer a memento of the DRS meeting to Dr. Boraskar.
Thank you very much, sir.
And also to offer a memento to our chairperson, Dr. Rajiv Chawla, big brother from Delhi. A token of appreciation for Dr. Kunal Punamya for joining us today. Thank you all. We break for lunch and we start sharp at 2 p.m. We have some interesting sessions in the post-lunch session, followed by high tea at 4:30 p.m. So I'm sure all of you will stay back. Do scan your badges for the MMC points. There's a scanning center, and the MMC observer is a very, very strict man who has told me that without the scans, the badges scanned, there are not going to be any points. So please scan your badges. Thank you.
Good afternoon. We now start with our post-lunch session, the topic for which is liver of the matter. I would like to call upon our chairpersons, Dr. Sibyl DeBrito ma'am from Mumbai and Dr. Anjali Rajadaksha ma'am from Mumbai.
Good afternoon, everyone, and welcome back for this postprandial session. Since our livers are also exceptionally active right now, it's very apt that we talk about the liver. So, for our first first topic, which is liver, the cause or the effect of metabolic syndrome, I would like to call upon Dr. Rajiv Chawla, sir. Sir needs no introduction. He's an eminent doctor from New Delhi. Doctor is trained at the Diabetes and Endocrinology Center of Western New York. He's a senior diabetologist and director at North Delhi Diabetes Care Center. Dr. Chawla is the past president of the Research Society of Study of Diabetes in India. He's past president of Diabetes in Pregnancy Study India. He's editor of various journals. He's an approved DNB teacher. He's authored many books and has received several orations. He's awarded travel research grant. He's instrumental in revising DIPSI guidelines in 2021. And sir is exceptionally proficient in his field. We are really happy to have you, sir.
Yeah, good afternoon. Thanks a lot for those kind words. Task assigned to me is liver in type 2 diabetes. Is it the cause or the effect of metabolic syndrome? So what I'm going to do is to explore the complex relationship between liver and diabetes, try to understand the liver metabolic role in type 2 diabetes, which seems again very, very complex, whether liver is a villain with insulin resistance leading to glucose and lipid dysregulation, whether liver is a victim which pays ultimately for insulin resistant, MASLD, fibrosis and cirrhosis, and toward the end the takeaways and the future directions for its management. So it is always like egg and hen theory, what came first, whether it is insulin resistance or type 2 diabetes, or it is the MASLD, which then sets in the stage for development of type 2 diabetes. So let's go back to our physiology days and try to understand that what came first. There's a huge evidence today that it is insulin resistance, which is a core defect which comes much, much earlier before the onset of even IGT or type 2 diabetes. In response to that, you have a growing beta cell dysfunction. Initially, there is a hyperinsulinemia to compensate for insulin resistance, but ultimately it is the beta cell failure which sets in the stage for development of type 2 diabetes, and per se because of that you have onset of postprandial hyperglycemia and subsequently the fasting hyperglycemia setting in. So when it comes to diabetes and liver disease, at least we understand they share a bidirectional dynamic relationship, because both the problems have important interaction considering its etiology and the presence of any problem into one organ ultimately leading on to dysfunction of the other organ. That means if you have insulin resistance leading on to type 2 diabetes, you are going to have per se hepatopathy. If you have already onset of MASLD, NASH, fibrosis, and then onset of type 2 diabetes. Because we know that liver is the main organ which is concerned with glucose homeostasis. It is glycogenesis which goes on in the postprandial state we are now, just now, because of release of insulin, and that leads on to deposition of glycogen. But moment we are fasting under the impact of glucagon, we have glycogenolysis and nucleogenesis contributing towards prevention of hypoglycemia in a normal glucose tolerant patient. So it is insulin resistance which is the root cause for the development of both adults onset type 2 diabetes as well as MASLD. So moment you have insulin resistance, it gets compensated, I told you in the beginning, by hyperinsulinemia. But per se, moment there is an onset of beta cell failure, there is an onset of hypoglycemia, it leads on to adipocyte dysfunction, reduction in adiponectin levels, free fatty acid levels are on the higher side, and so is sudden increase in triglyceride. And we know there are sterol regulatory element binding protein 1C, which is a transcription factor that plays a crucial role in regulating lipid metabolism as well as fatty acid synthesis, and so is carbohydrate response element binding protein, again regulating both lipid as well as glucose metabolism. So as long as there is a healthy liver and you don't have severe insulin resistance, moment there is an increase in insulin resistance per se leading on to some degree of beta cell dysfunction, hyperinsulinemia, that leads on to onset of what we as laymen say a fatty liver, and there is a lipotoxicity which then gets converted into NASH. There is a subsequent fibrosis, clinically significant fibrosis, onset of type 2 diabetes, and also there is towards the end A and C liver disease. And mind it is being predisposed to two factors. One is the genetic predisposition for development of MESL, and second is the environmental factors, the dietary factors, the sedentary lifestyle, all playing together. So it's a very, very complex, dynamic, bidirectional relationship between liver as well as into the glucose metabolism which goes on. The major pathways which induce NAFLD and their association with insulin resistance, diabetes, cardiovascular disease, non-alcoholic fatty liver disease, and end-stage fibrosis then could be either there is a strong hepatic genetic component. It is not only that you are being predisposed for development of diabetes at a early stage, maybe 1 to 2 decades earlier as compared to the Caucasian. You're also predisposed for a nephral, which also gets predisposed through various genes, which lead on to some degree of adiposity through induction of insulin resistance, NASH and fibrosis, but it is also being predisposed through strong lifestyle, adipose tissue deposit component, which is again predominantly driven by de novo lipogenesis on one end and predominantly driven by adipose tissue dysfunction on other end. So both playing together in a sedentary lifestyle, your flux of carbohydrate or diet intake is much higher, and then it leads on to nephral and progression into MASLD and end-stage liver disease. So moment you have insulin resistant state, it is directly going to be toxic to the hepatocytes. Again, trying to give you through a diagram that moment there is an increase in insulin resistance and hyperinsulinemia, that leads on to adipocyte dysfunction, reduction in adiponectin levels, leptin and TNF-alpha are on the higher side. There are higher free fatty acid levels. De novo lipogenesis is already onset, and that leads on to severe oxidative stress through the mitochondrium, and then that predisposes again for more steatosis, steatohepatitis, clinically significant fibrosis, and this process then goes on in its in terms of natural course of the disease over the time, over few years time. So the putative mechanisms which underlie the contribution or which lead on to development of nephral to the increased risk of further development of CVD as well as type 2 diabetes. Mind it, everyone who has a nephral or MASLD does not have diabetes per se. So if you have onset of nephral or NASH already there, that not only increases the risk of CVD but also towards the onset of adult onset type 2 diabetes, because through worsening of insulin resistance and further progression of nephral with free fatty acid production and inflammatory cytokines and reduction in adiponectin, it leads on to all the markers of inflammation going on the higher side like phenylalanine A and RBP4, CRPs, interleukin 6, TNF-alpha, high triglyceride production, and increase in small dense lipoprotein, which again worsens the scenario for developing of CVD, and there is going to be a further expansion of the visceral fat leading on to adiposity. And this process again goes on, leading on to, through I told you, through either through the sterol response element proteins or through carbohydrate responsive element binding proteins, and this further leads on to worsening of chronic liver disease and a end stage cirrhosis. So not only there is a effect of development of muscle on onset of type 2 diabetes, there is also per se effect of the diabetes on CLD, because moment you have worsening of insulin resistance, there is going to be a not only a increased risk for muscle and clinical significant fibrosis, but also there is going to be a further progression towards cirrhosis, which also increases the risk of HCC, which is very, very high, almost 2 to 3 times higher in type 2 diabetes as compared to someone who is not having diabetes. So it is not only insulin resistance or hyperglycemia which worsens muscle, but the liver disease onset per se or chronic liver disease, that also is going to impact on glucose control in 2 forms. There could be a predisposition to hyperglycemia, which is although not very frequent, but it is not very rare. It is usually seen when you have an acute and chronic liver failure in a terminal cirrhosis, or with the development of HCC, that you tend to get frequent episodes of hyperglycemia because there is hardly glycogen deposit by then, and it on the other end, contrary to that, it can impair your glucose intolerance and actually lead on to the onset of what is known as a hepatogenesis diabetes, which is for the first time developing in someone who already has cirrhosis, or even in patient those who already have a post-liver transplant situation or with HCC. So this association, trust me, is not by chance. Insulin resistance leading on to type 2 diabetes also setting up a stage for development of nephral or cirrhosis or HCC, but with the development of cirrhosis, you are also at a greater risk for developing hepatogenous diabetes. So it must be viewed as a continuum of the same phenomena, with core defect being an insulin resistance. So it is a vicious cycle. How liver disease and type 2 diabetes, they feed each other. Nephral prevalence is very, very high, up to 70%, or many studies saying up to 90% in the setting of type 2 diabetes. And with insulin resistance, that steatohepatitis with fibrosis going on further with profound insulin resistance also tend to impair your glucose control, leading on to hepatogenous diabetes, and together they lead on to an accelerated damage in the form of high risk for developing cirrhosis, liver cancer or liver failure. So this is actually a bidirectional relationship which creates all the more a dangerous feedback loop, where each condition actually exacerbates the other. So that is why today unfortunately the nephral prevalence is very, very high, and it must be viewed as a elephant in room. What we have been talking about, heart failure in diabetes, even nephral is as bad as is that, because there is going to be a much higher mortality. And if you compare it in diabetic versus non-diabetic, in diabetic the progression of fibrosis over 12 years is much higher as compared to someone who has no onset of diabetes yet. And there is going to be higher prevalence of clinical significant liver fibrosis in these patients. A published data in IGM 2024, Indian authors talking about that higher BMI, AST, ALT values, as well as lower platelet count, we all know are going to predispose to chronic clinically significant liver fibrosis. But mind it is not always ALT or AST which are going to be directly precursor of that. Many times your enzymes may be still just borderline and you might have a clinically significant liver fibrosis. So this study highlights the importance of screening for liver fibrosis much in advance, not only depending on the enzymes. And it is known that in type 2 diabetes, the progression of nephral to cirrhosis is also going to worsen the mortality, because mortality is much higher if you are already at the end of NASH, cirrhosis or HCC. Not only that, I told you in the bidirectional flow again, nephral also leads on to new onset of type 2 diabetes. Even if you were not diabetic, you were simply an obese with nephral, you are at a much greater risk for developing new onset of type 2 diabetes. So not only the genetic factors which are important, the double agent gene variant is extremely important, because this variant can both accelerate liver fat accumulation. I told you predisposition only for increased liver fat deposition. So you need to have a precision medicine. Today we are not only talking about precision medicine in type 2 diabetes, but also in management of liver, and we must try to understand these genetic nuances which have significant implication for developing highly tailored treatment, and be having more predictive risk factors or models for that. Because genetics adds another layer of complexity to liver involvement in setting of type 2 diabetes, and we understand there are going to be modifiable as well as non-modifiable risk factor. Non-modifiable, I told you, couple of genes which predispose for greater fat deposition, aging phenomena itself, and of course the modifiable risk factor in the form of weight regression and diet and exercise, which is going to be extremely important. So towards the end, I must tell you that liver disease possibly today is the leading cause of death in setting of type 2 diabetes. It is no more CVD or heart failure, but it is actually a diabetes related NASH, finally culminating into cirrhosis, which is going to have a very, very high mortality in these patients. So we must screen these patients with either FIB score or BARD or BART or EPRI or maybe NFS. There are a lot of tools which are available for prediction of fibrosis in these patients. Do a regular annual screening, but the challenges are that we need to specify, and the practical feasibility of having a widespread implementation across healthcare systems, and improving an access to and having an awareness of these screening tools possibly is going to be of paramount importance for a early intervention, and then only probably, just last one slide, we can, if we intervene early, we probably can check the progression from stress adipocytes toward hepatic lipotoxicity, inflammation, cirrhosis, and end-stage renal disease by intervening at each step. In the beginning, it may be lifestyle modification, then drugs to improve insulin resistance, to improve disposal of free fatty acids, reduce inflammation, and toward then antifibrotic drugs are fortunately now available which can check the progression towards cirrhosis. Weight loss is going to be extremely important. Drugs like semaglutide or Monjaro or the novel therapies which are already available, approved by US FDA, thyroid hormone receptor binding agonists, which are very, very expensive, not available in this part of the world. And of course, the last option is the bariatric surgery. So to sum it up, liver could be seen as a victim when we talk about sustained high glucose and insulin levels along with fat accumulation, but it could also be playing a role as a villain when we talk about insulin resistance, which not only impairs glucose production, but also contributes towards worsening of overall blood sugar control and leading on to hepatopathy. And understanding this intricate self-perpetuating cycle is going to be extremely important in terms of prevention and improve patient survival. Thank you very much for your patience listening. If you have any question, I'll be more than happy to answer.
Thank you, Dr. Chawla. We will be taking questions at the end of the session. So I call upon the next speaker, Dr. Saurabh Srivastav. He is Professor and Head of Medicine and Chief Medical Superintendent at Government Institute of Medical Sciences, Greater Noida. He has more than 50 publications in national and international journals. He has been Secretary to Editor on multiple journals, awarded Padmakar Tripathi Award, and awarded Investigator of the Year Award in BPCon 2017-18. I request Dr. Srivastav to start his lecture.
Thank you, Chairpersons. Thank you, Dr. Chawla, for giving me opportunity to be present over here. My topic is the management of type 2 diabetes in compensated and decompensated liver disease. I'm starting with the topic which Dr. Chawla has already covered. Why we are taking this? Because there is a high prevalence of type 2 diabetes mellitus in patients with chronic liver disease. It impacts the prognosis and increases the risk of complications, overall mortality. The decompensated cirrhosis is associated with renal dysfunction, hypoglycemia risk, malnutrition, and sarcopenia. There is an effect on drug metabolism and excretion of the drugs and needs a special focus as standard of diabetes guideline does not address the cirrhotic patients and management requires individualized and cautious approach. This has already been covered that the type 2 diabetes mellitus increases the risk of NFLD. The insulin resistance is an independent predictor of fibrosis in hepatitis C infections, hypersemia and hyperglycemia. They are associated with hepatitis C infections and C and B and diabetes mellitus and C infections. They have a bidirectional relationship that in diabetic patients the incidence of hepatitis C infection is more, and in C infected patients the risk of diabetes is also more. As sir has already discussed that the patient of cirrhosis have more chances to have diabetes, IGT, but close to 100%, that is nearly all patients are insulin resistant. And fibrosis is the thing which is increased with the prevalence of diabetes mellitus. And insulin resistance, if we see this chart that the sir has already told that in liver cirrhosis there is a decreased hepatic clearance of insulin leading to hyperinsulinemia, and this hyperinsulinemia increases the risk of increase the incidence of counterregulatory hormones, and the insulin resistance in the liver and the muscles, which in the liver it might lead to diabetes, and the other factors also are responsible for decreasing the function of beta cells. So all the setting is of hyperinsulinemia, and this is the thing which sir has already told as hepatogenous diabetes, that there is an incidence of hyperinsulinemia in cirrhotic patients. There is insulin resistance and ultimately beta cell dysfunction, which can lead to diabetes even if the patient is non-diabetic and is only having chronic liver disease. This has already been discussed, but one important thing that in Indians, in Asian population, we have lean NFLD also. The person are lean, but still they are having NFLD, and this has already been discussed that there is a bidirectional relationship between type 2 diabetes mellitus and NFLD. NFLD can lead to insulin resistance, which can ultimately lead to type 2 diabetes, and type 2 diabetes can lead to ultimately NFLD. So there is a vicious cycle which one is before, which one is after is not there. And impact of diabetes on various stages of liver disease, we can say in normal liver, it predisposes for NAFLD. In chronic liver disease, there is a faster progression of fibrosis. In end-stage liver disease, there is a decrease in overall survival and the risk of complications. And liver transplantation, again, there is an increased risk of diabetes mellitus. So it is linked to increased incidence of hepatic encephalopathy, variceal hemorrhages. It is an independent predictor for bacterial infections. It has increased risk of hepatocellular carcinoma, and it significantly decreases the survival rate if the patient of CLD is having diabetes mellitus. There are numerous studies which depict that there is an increase in complication of CLD in patients in the presence of diabetes, and there is an increased mortality in the patients of CLD if the patient is having diabetes. So if we go for diagnosing and monitoring of the decompensated CLD, the important thing is that we must remember that the fasting plasma glucose is a gold standard for diagnosing diabetes, but the threshold for fasting plasma glucose decreases in chronic liver disease, and it is not being justified, but it has been said that the cutoff of 126 is lowered in cirrhotic patients, and it should be around 110 to take the patient as diabetic. Postprandial glucose again is a factor by which we can diagnose, and OGTT is the gold standard. HbA1c has a debatable role in patient of chronic liver disease because of the decreased erythrocyte survival. The alternative biomarkers can be glycated albumin, fructosamine, and the important thing is that we can go ahead with the self-monitoring of blood glucose and CGM. Coming to the management, which was the main topic, in the absence of specific guidelines, the treatment of diabetes mellitus in patients with CLD starts from the general principles of management. That is, if we see a patient of type 2 diabetes, then be compensated or decompensated. In decompensated liver disease, the only option is we have to give insulin. However, in compensated liver disease, all the drugs can be used with or without caution and can be avoided. We can go ahead with them one by one. The important point to remember in patients with CLD is that the fasting blood glucose may be lower in CLD and cirrhosis. Glycated albumin may be unreliable in cirrhosis, especially in patients with shortened lifespan, red blood survival. Glycated albumin and fructosamine reflect glycemic status more accurately, and self-monitoring of glucose and CGM can be considered. The challenges which we face are diagnostic difficulties, which we have already discussed. There is a high risk of hypoglycemia because of reduced insulin clearance and low glycogen storage and impaired glucogenesis, as Sir has already told. There can be drug-related issues due to decreased altered hepatic metabolism and protein binding, portosystemic shunting leading to higher drug levels because of decreased first-pass metabolism, and risk of hepatotoxicity with some agents. And there are other challenges are cognitive impairment because of encephalopathy, renal dysfunction, and malnutrition and sarcopenia complicating with diet therapy. The targets for decompensated liver disease, we should go for relaxed targets, as AD has already said that there should be less stringent A1C goals for the patients who are having limited life expectancy, extensive comorbid conditions, and advanced micro and macromolecular complications. So, child-pug A is basically compensated cirrhosis, and B and C are basically decompensated cirrhosis. So, in A, we can have a target of less than 7.5, and B and C, we can have A1C target of around 8. The fasting plasma glucose should be kept between 90 to 150, and postprandial glucose should be below 200. Diet is most important, in which we should achieve a weight reduction of 5 to 10%. The accepted approach is we should start off with, as there is a incidence of sarcopenia also, we accepted approach is about 35 kilocalorie per kg body weight per day should be given, and then we subtract 5, 10 or 15% in case of mild, moderate or severe ascites. And this should be the average requirement of the body weight. Protein intake should be 1.2 or 1.5 gram per kg body weight, and deficit of vitamin should be supplemented. Physical activity is very important because it is also recommended for NAFLD, and the aerobic and resistance training exercises can be done. So to summarize the lifestyle intervention, caloric needs is 35 to 40 kilocalorie per day, protein intake 1.2 gram per kg per day, and sarcopenic patients or malnourished patient 1.5 gram per kg per day. Meal planning, it should be small, frequent meal, high protein, late night complex carbohydrate snack, and avoid prolonged fasting. Physical activity should be done, and we should avoid excess calorie restriction because it worsens sarcopenia, and processed food and fructose rich beverages should be avoided. Coming to pharmacotherapy, It is guided by child book score. We can take one by one. Metformin, it has benefits of improving insulin resistance. It promotes weight loss. And it promotes, it is usually weight neutral. It decreases the risk of HCC and encephalopathy if given in the patient of compensated cirrhosis, and improve survival. The only factor is that of MALA, that is metformin associated lactic acidosis, and it should be not given when the eGFR is less than 30. So coming to the where it should be used in child book A and B, it can be used with the lower dose, that is less than 1 gram per day, and child book C, it should not be used. Sulfonylurea and meglitide, they should not be used in any of the drug, either decompensated or compensated cirrhosis, because they had a increased persistence of having hypoglycemia, and they are potentially hepatotoxics. Coming to thiazolidines, they improved steatohepatitis, so it is better if the patient is having NASH. The concern in cirrhosis is that there is an increased risk of fluid retention, edema, ascites. It can worsen osteoporosis and can possibly increase cardiovascular risk, and there is limited data in advanced cirrhosis. So in child book A, it can be used with caution, but B and C and decompensated CLD, it should be avoided. DPP-4 inhibitors, the safety is in all the cirrhotic patients because they are weight neutral and they have lower hypoglycemia risk. However, in renal impairment, the dose should be adjusted. The linagliptin has the safest renal profile, so it can be given. In A, it can be given. B, it can be used with caution, and C, it should be avoided. The important thing with DPP-4 is that some of the studies have shown that it increases the risk of going into complication, that is encephalopathy, and progressing to fibrosis is more with DPP-4 inhibitors, but it is not well documented. Coming to GLP-1 agonists, they have a benefit of weight loss and improved NASH and lower hypoglycemia risk, so they can be used. It is not metabolized in liver, but exenatide and lexazinide should not be used in renal failure. Again, A and B, that is compensated cirrhosis, we can use it, but in decompensated cirrhosis, it should be avoided. Similar in SGLT2 inhibitors, they improve glycemia and weight, improves NAFLT and acidosis. The case report that it decreases edema and ascites, taken into consideration diuretic-like action. However, concerns are hypotension, urinary infection, and less effective when the GFR is less than 45. So, in A and B, they can be used. A, they can be used. B, with caution. But C, it should be avoided. Alpha glucosidase inhibitor, again, they improve the patient having hepatic encephalopathy because of they decrease proteolytic flora and amino production. They increase saccharolytic flora and have mild laxative effects. So they improve hepatic encephalopathy. So they benefit in cirrhosis. However, they have minimal systemic absorption, so they are safe in cirrhosis also. So they can be given in child book A and B, but in C it should be avoided. Insulin therapy, it is preferred for decompensated cirrhosis. It is reliable when all drugs are contraindicated. The challenges are that there is a hypoglycemia risk, there is a weight gain and association of increase with hepatocellular carcinoma in some studies. How to start? It should be started with the 25 reduction dose with the dose of 0.1 to 0.2 unit per kg per day, and the prandial insulin can be added with the largest possible meal. It can be either 4 units or 10 units, 10% of the basal dose, and titrated every 3 to 4 days. And monitoring should be SMBG or CGM. So this is the main protocol. The patient with diabetes, we should start off with lifestyle intervention, then pharmacotherapy. If the patient is stable, not acute event, or in A category, then if we are having hypoglycemia risk, then we should consider the drugs which are having low hypoglycemia risk, such as SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, and alpha glucosidase inhibitor. However, sulfonylurea should be avoided. If the concern is obesity, then weight neutral drugs or weight losing drugs should be used, such as SGLT2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors, but sulfonylurea and pioglitazone should be avoided. In renal dysfunction, renal safe drugs should be used, such as linagliptin, SGLT2 inhibitors, but the exenatide, lexazinide, and metformin should be avoided if the eGFR is less than 30. If the patient has encephalopathy, then the patient, the drugs which improve encephalopathy, such as alpha-glucoside inhibitors, they should be used, and the targets should be kept lower, considering which have low hypoglycemia risk. If there is poor control, then we ultimately switch to insulin. However, if the patient is having decompensated cirrhosis, then the insulin should be started, as already we have discussed. This is the titration regime which I have already told about, that we start off with 0.1 to 0.2 units per kg body weight, and we increase gradually. The fasting plasma glucose is 90 to 150. In NFLD, as Sir has already discussed, coming to a special consideration in patients of hepatic encephalopathy, having cognitive impairment, we should avoid secretagogues and long-acting insulin, and frequent glucose checks are needed. In renal dysfunction, metformin should be avoided. In DPP-4 inhibitors, linagliptin is the safest, and exenatide and lexazinide, they should be avoided. In sarcopenia and malnutrition, the protein requirement should be around 1.2 to 1.5 kg per day, gram per kg per day. Avoid strict calorie restriction and prefer agents that do not worsen muscle loss, such as GLP-1 receptor agonists and DPP-4 inhibitors. If the patient is having hypoglycemia risk, then high in decompensated cirrhosis due to decreased glycogen glycolysis, so use metformin in the low dose, DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2, AGI wherever possible, but sulfonylurea should be avoided. In transplant, we can skip this. You can see in this chart, child book A, B, and C, all the insulin can be allowed in all the cases. If we go for sulfonylurea, it is not recommended in any of the thing. Meglitide is again non-sulfonylurea like secretagogue, it should be avoided. Metformin, child book A and B, glitazones A and B, DPP-4 inhibitors A and B, GLP-1 A and B. However, exenatide and liraglutide should be avoided, and alpha-glucoside inhibitor A and B, and SGLT2 inhibitor A and B. So in child book classification, A and B we can use, but in C, that is decompensated cirrhosis, it should be avoided. So this we have already discussed. So we can start off with lifestyle interventions. We can assess the child book class, start off with safe OADs. Then if patient is in B or C, then we start off with insulin and monitor with SMBG and CGM. And in special situation, we should act accordingly. So the take-home message is insulin is the safest and preferred therapy in decompensated cirrhosis. While oral agents may be cautiously used in compensated state, management should be individualized, balancing safety and glycemic control. Thank you.
Thank you very much, Dr. Srivastava, for that exhaustive explanation. Moving on to our next topic, which is MSLD and role of dual PPAR agonist. To talk on this, I would like to call Dr. Shalini Jaggi. Madam is Consultant and Director at Life Care Diabetes Care Centre, New Delhi, Fellow of Royal Colleges of Physicians of London, Edinburgh and Glasgow, Fellow of the American College of Endocrinology.
That's okay, ma'am. We can start.
Over to you, ma'am.
So good afternoon, everyone. My task has been made much easier by the previous two speakers, and this is a company-sponsored session, but I'm not receiving an honorarium. The slides belong to the company. So the topic that is allotted to me is talking about MASLD and how the dual PPAR fits into management of MASLD, especially in the Indian setting. What we need to understand is the change in the nomenclature from NAFLD to MASLD happened because of two main reasons. One, because we know that fatty liver is commonly associated with one or the other metabolic risk factors. It could be a dyslipidemia with a high triglyceride, or maybe a low HDL, or maybe dysglycemia, prediabetes or type 2 diabetes, obesity, high blood pressure. So basically, MASLD encompasses steatotic liver disease, which means more than 5% of fat in the liver, along with one of these cardiometabolic risk factors. So clearly, Dr. Chawla has beautifully described MASLD and its pathogenesis and everything. So basically, what you need to understand is anybody who has a documented steatotic liver disease with more than 5% of fat, which has been confirmed either by imaging or by biopsy, along with any one of these risk factors that I talked about, then you classify this patient as MASLD. Of course, under steatotic liver disease, you also have a few more entities. which includes somebody who's got MASLD, which means metabolic risk factors with fatty liver, along with alcohol intake, which is significant. So that is now called as MET-ALD, which means MASLD with increased alcohol intake. This could be between 20 to 50 grams per day in case of females and 30 to 60 grams per day in men. Of course, this is a separate entity from alcohol liver disease, where we clearly know the culprit for the liver pathology is essentially an increased intake of alcohol. And then you have all the other causes, which could be cryptogenic and all the other secondary causes of liver disease. Now, prevalence of fatty liver, we know, globally also very high, almost 25%. And then in India, we have a huge prevalence of fatty liver. And now the problem is young people, pediatric, the children, adolescents, we are seeing fatty liver in these populations also. MASLD and metabolic conditions, a hand-in-hand type of situation. Percentage association of metabolic conditions, you can see 90% association with obesity, 70% with type 2 diabetes, 68% with hypertension, so on and so forth. And why MASLD becomes more important is because patients with MASLD are 2 times more prone to develop even end-stage renal disease with a worse CKD prognosis. So clearly, steatosis and fibrosis have a huge prevalence in our country. Insulin resistance is the root cause and has been explained beautifully, so I won't delve much on this. The 2-hit theory for MASLD progression, all of us know. The first hit on a healthy liver is essentially the metabolic parameters, which could be an increase in the triglycerides, the obesity, gain in weight, type 2 diabetes because of the insulin resistance, which is underlying, of course, all on a sedentary lifestyle, resulting in fat depositions in the liver. And the second hit on a genetic predisposition with this metabolic dysfunction, the change in the gut microbiota. Now we know there's a whole plethora of gut. There's oxidative stress, ROS generation, endocrine, the ER stress along with mitochondrial dysfunction resulting in NASH, which is severe hepatitis, progressing eventually to cirrhosis and even HCC. So pathological association between MASLD is established with all the different metabolic parameters, including complications of CVD and CKD. And we know in patients with type 2 diabetes, it is worse. So the progression of NAFLD to cirrhosis and related mortality is much higher in patients with type 2 diabetes compared to non-diabetic people. And therefore, when we talk about management, the EASL, EASD, ESO clinical practice guidelines clearly talk about liver care being a primary focus, especially in patients who are obese or have type 2 diabetes. So early screening is very, very mandatory for all our patients, and therefore a simple routine ultrasound can give you an idea of whether there's fatty liver or not. And then FIB4 index, a very, very simple handy tool, and I'll show that to you. All you need to do is just take, all of us have smartphones. So all you need to do is put 4 parameters and you get the FIB4 index. So if the FIB4 index is less than 1.3, you just need to reassess the patient and follow him up at least 1 to 3 years. High risk patients every year, just do the calculator and you can get it. Between 1.3 to 2.6 is indeterminate, and therefore you need to actually look at all the existing comorbidities and manage them, or send a patient for a fibro scan. I'll come to that in a little while. Of course, somebody with more than 2.67 established case, and that is where you need to refer this patient to a multidisciplinary team, including a hepatologist, a lifestyle expert, talk to him about diet and weight loss, so on and so forth, and pharmacotherapy or bariatric surgery, which we'll come to. So this is the FIB4 index. 4 parameters is all that you need: age of the patient, his AST, ALT levels, and the TPC, total platelet count, and you get the So clearly it's a very simple calculator. Less than 1.3 rules out fibrosis. More than 2.67, we know there's established fibrosis. Between that, you need to follow this patient up. It's as simple as that. Now, FIB4 is directly proportional to CV events, all-cause mortality, and liver events. So clearly, this is an established score, which you can do easily, just takes 1 minute, and then you have a kind of an approach on what you want to do with this patient. Now, FibroScan or VCTE, the vibration controlled transient elastography, is something that all of us have started adapting and doing it. Clearly, it is a system that gives you an idea by measuring 2 parameters. One is looking at the liver stiffness measurement, the LSM, which is measured in kilopascals, and then you have the controlled attenuation parameter or the CAP score. So the LSM in kilopascals is basically a non-invasive quantification of the liver fibrosis, and the CAP score gives you an idea of how much is the fat in the liver, gives you an indication of the liver steatosis. Something as simple, patient just has to lie down, it's like an ultrasound. So with a probe, you have a medium probe, an M probe, and you have an XL probe for people who are obese. So clearly with these you get an idea. So interpretation is very simple. A CAP score less than 237 tells you that steatosis grade is 0. So there's less than 10% of liver showing fatty change. A CAP score between 238 to 260 is a steatosis grade 1, telling you that about 11 to 1/3 of the liver, less than 33% of the liver has fat. 261 to 292 tells you that almost 35 to 66% of the liver has fat, so a S2 steatosis score. And more than 293 clearly tells you this is a grade 3 fatty liver with more than 67% of the liver having fat. The LSM score that I talked, the liver stiffness management, the kilopascal, you get a reading of 14%, 12%, 11, you know. So less than 7 is normal, F0, which tells you there's no fibrosis as yet. 7.1 to 10 is mild fibrosis. More than 10 is something very important, moderate fibrosis. Beyond 13 is severe fibrosis, and cirrhosis is more than 16. So once you have a CAP score along with a liver stiffness measurement, you get an idea of how much is the fat and how much is the steatosis, so that you can follow up your patient based on the management that you decide. Now on an Indian perspective or globally, of course, lifestyle, weight loss remains the mainstay for management of metabolic AST. So clearly patient needs to lose weight. So it has to be diet, weight reduction, management of comorbidities, dyslipidemia management, obesity, metabolic syndrome, and of course pharmacotherapy or bariatric surgery as and when indicated. So we need a multidisciplinary team approach for managing MASLD. Of course, it has to be a primary care provider or an endocrinologist or a diabetologist, simply using a FIB4 and then maybe a fibroscan or along with an ultrasound to tell you what is the grade and how you want to go about it. Talking about weight management, medical intervention, very important. A hepatology consult in case you get severe fibrosis. The way forward is something that you need to go hand in hand in terms of a multidisciplinary approach. And of course, cardiological, lipid management, health, psychology, nutrition, lifestyle intervention are very, very important. Weight loss, we know weight loss helps in improvement in the fat in the liver. Nutrition, education, physical activity, restriction of alcohol intake, behavioral therapy, all of them are very, very important aspects. And of course, this is what I want you to talk about. Something as much as 3% of weight loss, if your patient is able to achieve, you know, 35 to 100% of the patients will show a slight improvement in steatosis. About 5% weight loss, ballooning and inflammation improvement is seen. 7% weight loss, there's resolution of NASH. 64 to 90% of patients will show you a resolution of NASH, and more than 10% weight loss, fibrosis regression has been documented. But the problem is sustaining the weight. You know, losing weight is still easy, but then keeping it down is something which is very, very important. And, you know, we have a lot of weight loss drugs and therapies available. We'll not go into that today. Moving on, the dual PPAR agonist that we are using a lot in our Indian patients in terms of its role in management of MASLD is something very, very important. Saroglitazar, the name Saro is, you know, Gujarati word, Saru is acha, good. So saroglitazar, the good glitazar, it is a metabolic solution for metabolic dysfunction. So it is the India's first NCE which is approved for atherogenic diabetic dyslipidemia, especially in terms of lowering the triglycerides. And of course, approval for NAFLD came in 2020. So in India, it is approved as a drug that can be used for NAFLD. And I think all of us have been using it in our clinics and we see a good improvement in our patients. So the mechanism of this dual PPAR agonist is through the PPAR alpha as well as the PPAR gamma action. PPAR gamma, like glitazones, we know. Insulin sensitivity improves, there's improvement in glycemic control, the HbA1c levels come down, glucose metabolism is enhanced, so clearly it shows a clear improvement in the liver pathology. And of course the PPAR alpha, what we see in the fibrates, the lipid metabolism regulation, there's increase in fatty acid beta oxidation in hepatocytes, fatty acid delivery to the liver is reduced. So clearly a reduction in triglyceride levels along with LDL reduction is seen, all of this improving the metabolic dysfunction. And of course, the inhibition of the inflammatory pathways. We talked about insulin resistance and the inflammation and the oxidative stress contributing to the mast cell pathology. So this is one drug which is not only working through the PPAR alpha and the PPAR gamma promotion pathways, but also inhibiting the inflammatory pathways in terms of the MAP kinase and the NF-kappa beta. So clearly the anti-inflammatory effects lead to a reduction in the liver fibrosis growth factor and a reduction in the fibrosis progression. So this is some of the data, the studies that show how saroglitazole leads to improvement in glucose metabolism and improvement in insulin sensitivity. You can see here, these are treatment-naive patients with type 2 diabetes, HbA1c between 7 to 9, fasting triglyceride more than 150, randomized to saroglitazole 4 milligrams and placebo 1:1, followed up for 16 weeks, and you see an improvement in insulin sensitivity as well as the glucose metabolism parameters improving. This is an American study or a phase 2 saroglitazole efficacy study in NAFLD patients, 104 patients, followed for 16 weeks, and clearly again you can see here very beautifully the absolute percentage change in liver fat content with saroglitazole coming down and liver fat reduction by almost 10%. Seen in a good 55% plus patients, and percentage of patients with liver fat reduction by almost 30% you see in 41% compared to placebo. Now this is another study looking at the effectiveness of PPAR agonist saroglitazole in NASH patients, a biopsy-driven phase 3 study from India. Again, clearly you see saroglitazole in one arm, placebo on the other arm, a follow-up of 52 weeks followed by a safety follow-up of another 6 weeks plus 6 weeks. So you see an improvement in the NAFLD activity score of more than 2, seen in almost 52% patients without a worsening of fibrosis at week 52. This is the AMRI FibroScan study. Again, 112 patients with NAFLD. This is all Indian data. So you can clearly see the efficacy and safety of saroglitazole in real-world patients of NAFLD with or without diabetes, including compensated cirrhosis from a tertiary care center. So again, over 52 weeks, you will see an improvement in all the fibrosis parameters in patients who were given saroglitazole over almost a 1-year period. This is another poster presented at EASL SLD Summit 2023, a 96 weeks and a 144 weeks follow-up on saroglitazole in MASH patients with related compensated stiffness from 22.8 at baseline coming down to 10.9, and the CAP score improving from 282 to 241. This is again Lead India EMR data showing how saroglitazole not only has improvement in terms of the liver scores, but the triglycerides come down, the LDL improves, and the liver enzymes also show an improvement. Again, a significant reduction in HbA1c also, because of the PPAR gamma action. Glitazones work through the PPAR gamma pathway. This is again a dual PPAR. So besides the PPAR alpha is leading to triglyceride lowering, and the PPAR gamma is causing HbA1c lowering. And no worsening of renal parameters. This is the follow-up of serum creatinine and eGFR. You can clearly see even after 15 months of therapy, it has a non-renal route of elimination, so there's no worsening of renal function observed. So clearly, saroglitazole today finds a mention in 3 major Indian expert consensuses: the Lipid Association of India 2020, the RSSDI 2022 expert consensus, and the INASL 2023. So as of today, in current standard, I'll just take one more minute. NASH plus minus hepatic fibrosis, anything from F1 to F3. In patients with diabetes as well as non-diabetics, you have an off-label use of pioglitazone, vitamin E. Saroglitazole is the only one which is recommended. And you need to give it for a minimum of 12 months to actually see a good improvement. Just giving this drug for 3 months or 4 months and stopping it will not lead to a good improvement. Although you start seeing those changes there, but for a good change, a minimum 12-month treatment duration is required. So when it comes to the INASL recommendations on off-label drugs, we know vitamin E is not approved for NAFLD or NASH and is recommended in NASH only in patients without diabetes. Glitazone, pioglitazone, we all know it has an indication, especially in our patients with type 2 diabetes, for improvement in NAFLD and NASH. UDCA again not approved for NAFLD and NASH and has no impact on liver fat and fibrosis. So to summarize, when it comes to MASLD, we need to understand this is metabolic dysfunction associated steatotic liver disease, redefined from NAFLD, so removes the stigma of the word alcohol. You know, somebody who's not had alcohol, You label him as NAFLD, so non-alcoholic, so that has a huge stigma, so the terminology has changed. Association with one cardiometabolic risk factor, it could be obesity or overweight, it could be dysglycemia, prediabetes or diabetes, it could be hypertension, it could be a high triglyceride, low HDL, all of these you need to satisfy at least one criteria out of these. Screening, very simple. I showed you the FIB4 index. Simply use your smartphone, put in those 4 numbers, and you'll get the FIB4 index. A simple ultrasound will tell you about the fatty liver, and then you can do a fibroscan to actually find out the liver stiffness and the CAP score, the steatosis level. Of course, like I said, lifestyle modification and weight reduction remains the first line management. Sustaining the weight loss is very, very important, and we have all the newer drugs that have been discussed. So drugs like saroglitazar, the dual PPAR agonist, is the only approved medication to treat MASLD or MASH in India, which can reduce liver enzymes, liver fat, as well as fibrosis score. Thank you so much.
Thank you, Dr. Jaggi. Any questions from the audience to any of the speakers?
Good afternoon, everyone. As Dr. Chawla sir said about the vicious cycle, Sir also said about the glycated albumin and fructosamine, and Shalini ma'am also discussed about the dual PPAR agonist. These all things are for the diabetic and MASLD. What is about alcoholic liver disease?
What is the question?
This is all about MASLD.
This is all about MASLD. Alcoholic liver disease has been separated from that because that is not primarily insulin resistance induced. The pathophysiology of ALD is absolutely different. That is a drug abuse which leads on to alcoholic liver disease. What we have been talking is metabolic associated or dysfunction associated liver disease or steatohepatitis, where insulin resistance is a crux problem and that leads on to further worsening. ALD is not neither in terms of causative nature nor in terms of treatment. It is absolutely different.
ALD is a drug-induced secondary cause of liver problems. So taking off alcohol and all these other therapies will work there. Only MET-ASLD was one entity I talked about where you have fatty liver, where you have an obese person, but the alcohol intake is again significant. So that has to be treated for both.
See, aim in insulin resistance is one is to reduce weight and to somehow reduce insulin resistance. That is why you have drugs like PPAR gamma or alpha combinations or pioglitazone as such, or even vitamin E, or primarily weight reduction to reduce insulin resistance.
Good afternoon, everyone. My question is like in chronic liver disease patients, whenever we start treatment for diabetes, generally there are episodes of morning hypoglycemia. Even if you give basal insulin or titrate the dose, we generally see patients coming up with morning hypoglycemia. So how do we go about managing those patients?
As I already told that we have to reduce the dose, whatever dose you are calculating, you have to reduce the dose by 25%. So, and then you have to, and it is just a matter of titration. You have to titrate the dose in which the hypoglycemia is not occurring. Because hypoglycemia, as I have already told, that there is a proneness for hypoglycemia in liver disease.
CLD glycogen stores are depleted. So that for hypoglycemia, the risk is much more. So I think using a low dose sulfonylurea or titrating insulin doses based on SMBG or CGM values is very important.
That is why long-acting sulfonylureas are to be avoided, and all the drugs after stage 2, moderate hepatic insufficiency or child POC B, you need to reduce it to 50% and subsequently to 25%. And that is what he said in his final message, that is why insulin is the safest, shortest acting, or short acting with very low dose of basal if required. Basal actually may not be required at all because there are hardly any neoglucogenesis happening. So no fasting hyperglycemia. For postprandial reduction, you just need 4 units, 5 units of prandial insulins.
Thank you.
So just for the benefit, and I'm sorry, I don't know if that was already discussed, but the role of saroglitazar and also in hypertriglyceridemia, and again the combination with fibrates, because often when we see patients, they are already in a statin fibrate combination.
Yeah, that is important. Yes, co-prescribing saroglitazar with a patient who is already on a fibrate is not indicated. You need to take him off the fibrate when you add a saroglitazar. The statin can definitely continue, so you can co-prescribe it along with a statin, but not with a fibrate. Both of them are working through the PPAR alpha mechanism. Fibrate is pure PPAR alpha. This is a dual, so this is PPAR alpha along with PPAR gamma. So you don't need to give a fibrate when you're giving a saroglitazar.
See a lot of patients with low albumin. How you all tackle that patients? Like what is your, in short, actually it's a very big topic, but some nutshell if you can tell us.
See, these patients need to be supplemented with regular albumin, and that is why it is practiced that if you are already having a patient who has established cirrhosis more than childhood B or end-stage liver disease decompensated, they need to be given albumin on regular basis. A common practice is give them diuretic along with albumin on weekly basis, and that keeps albumin at least more than 3. Target is at least more than 3.2. So maybe a dose of vitamin K if PT-INR is high, a low dose diuresis, and a IV supplementation of albumin on once to twice weekly basis.
Because
I
synthetic
have one
function is
last
impaired.
question.
Synthetic function is impaired, so albumin should not be given. Albumin has to be given.
Because they won't synthesize, even if you give them a lot of protein, they'll not be able to synthesize albumin, so it has to be supplemented on regular basis.
Is it okay to stop saroglitazar after achieving the desired result? And what is the sustainability of the effect after stopping the drug?
I think that's what I showed you. Minimum you need to give it for 12 months depending on the improvement. You can continue it for a longer period because of the safety. There's hardly any contraindication there. But maybe once you've achieved, you can stop the drug and observe the patient and monitor the patient for further.
Then follow the lifestyle, which is
Yeah,
very
lifestyle and weight loss. That's what I said. Losing weight is easy. Sustaining that weight loss is the most difficult part.
Thank you very much, speakers. I think we'll conclude
Thank
the
you.
session here.
Thank you.
Felicitate the speakers with mementos.
चौपाटी वाले में वो आ रहा है बीच साइड वो वाटर का जो फ्लैश आ रहा है.
Thank you for a very informative session and discussion. Moving on to our next session, risk management in diabetes. I would like to call upon the chairpersons, Dr. Ramesh Dargat sir from Mumbai and Dr. Nikhil Nashikar sir from Mumbai.
Dr. Dargad is not there, so I would like to go ahead. Next, I would like to invite Dr. Pia Balani. She is an endocrinologist from Bombay Hospital, multiple publications, and her topic is type 2 diabetes with 3 risk factors, identifying and managing the high risk type 2 diabetes.
Thank you so much, Chairperson, and thank you to DRS, Purvi, Manoj for inviting me here today. Thank you, Astra, for inviting me for this particular talk. So good afternoon, everybody. My talk today is about a very clinically important subset of patients that all of us see in our day-to-day practice. And this we're talking about patients with type 2 diabetes alongside with multiple risk factors, more specifically those patients who have 3 and more risk factors alongside with their diabetes. Now, if one thinks about our day-to-day practice, this actually happens in more of our patients than we actually kind of, imagine. If you really think about the number of patients you see with diabetes and that extra hypertension or dyslipidemia or age also being counted as one of the criteria right now, or basically obesity, well, that number is fairly high. So let's go a little bit deeper into this, understand why we need to identify this set, understand why we need to manage this set more aggressively than our routine diabetes patient. So the habit for us so far has been, today if I have my diabetes patient who comes into the clinic and this patient turns out to have high cholesterol, I will start the patient off on a statin. And the patient comes the next time and you see that he's had a couple of BP readings, maybe a little higher, and you know that this patient needs to be put on an antihypertensive. You will start off that kind of medication, you'll start an ARB. So basically what we are doing is managing each comorbidity in a silo. What we are not doing is stepping back, zooming out a little bit and thinking that with one extra risk factor, we are not just dealing with 1 + 1 = 2 risk factors. What we are dealing with is actually a multiplicative effect. It is not an additive effect. It is actually a multiplicative effect in terms of cardiorenal risk status. And add to that mix, let's say a third or even a fourth risk factor, let's say if albuminuria, for example, comes into this risk, basically this level of risk becomes actually exponential. Now, this kind of subset of patients, what we need to realize, needs that extra recognition, needs that extra care, and more aggressive management also as well. Dr. Dargad, good afternoon. Yeah. So today what my talk is basically comprising of is the need to risk stratify these patients, how we risk categorize in terms of guidelines, in terms of the count of the number of risk factors, how we are managing this cardiorenal risk for these patients with type 2 diabetes with multiple risk factors or by the KDIGO class. What does the ADA have to say about this kind of group? What is the effect of genetics? Does it make a difference to be on genetics versus the innovator molecule? And ultimately, what is our goal for this subset of patients? So moving forward, basically, let's understand that today, what is the need for this risk stratification? Well, today, if I have a patient, let's say these are patients, what I'm showing you in this bar graph, they have been categorized based on their renal risk by KDIGO. So you have a KDIGO low risk, moderate, high, and a very high risk. All of these patients, diabetes control, same, well-controlled patients. But if you look at the second two areas, you're talking about the moderate and the high risk and the very high risk, you know that this group of patients with KDIGO high risk or very high risk is going to have a completely different trajectory in terms of their cardiorenal outcomes over the next 5 to 10 years. The point being over here that the A1C control alone, glycemic control alone is not our job. We need to understand that this set of patients needs special and different care. So now risk stratification in type 2 diabetes is not only about checking the box, checking those 20 boxes, whether I have this risk or have that kind of risk. What we are trying to identify over here is a more vulnerable population amongst our patients with type 2 diabetes. How high is the risk? I remember when I was doing fellowship for that matter, patients who'd already had a cardiac event, who already were in high stages of CKD, we would say, this is a very kind of high risk population. Let's get them into hypoglycemia. We can maybe treat them a little less rather than treat them a little more. But now that entire narrative has changed. Because when we have the higher risk group, a more vulnerable group, given the agents, the intensive strategies, the cardiorenal protection that we have available with us today, our whole outlook on diabetes management and risk stratification has completely changed. So what are the different methods we have available to us today? Well, clinical risk factor assessment, if you really think about it, I think each of us is already looking into all of this. We might not look at the bigger picture, like I said earlier, but no doubt we are looking at the major risk factors: hypertension, dyslipidemia, smoking, albuminuria, age. So these are the risk factors specifically that we are looking when we are doing this kind of assessment. What is the advantage? Well, it's simple, it's rapid, it's guideline-based, and for that matter, it's very, very practical, probably in our clinics, and actually has been endorsed even by the ESC, by the EASD in 2023, and by the ADA in 2024 also. We do have other risk scores, risk calculator, engine, Framingham, Recode. This gives individualized risk protection, and there is data about this, but honestly speaking, if I was to ask this audience over here, how many of us are really patient upon patient using these risk calculators? I would say I am a failure itself when it comes to using these kind of calculated scores. Guideline-based risk categories, well, the ESC, EASD, well, which classify risk with moderate, high, very high, etc., are based on history, duration also. We'll talk about that a little later. And then we have imaging, non-invasive testing, like the coronary artery calcium scores, carotid IMT, ABIs, and the biomarkers HSCRP, NT-proNB, also different methods for the purpose of CVD risk stratification in our patients with type 2 diabetes. So let's look a little more in detail at the guideline-based risk categories. So KDIGO, for example, well, this is a very often used tool incorporating not only eGFR, but also with the addition of albuminuria, has really kind of helped us understand the projections, or rather the prognosis for our patients with CKD as well. So imagine today, if I have a patient who's in G3A, let's say I'm sorry, I'm not sure this is working. So let's say a patient eGFR is 55. So this patient, as per this, would fall into a G3A. Now imagine if I had an albuminuria level of 10, which would make this patient fall into the A1 category, which is actually at moderately increased risk, versus an albuminuria level of 450. Directly same G3A, but can go from the yellow to the orange to the red. Prognosis completely and absolutely different. Basically indicating again that risk stratification for this kind of CKD patient who has a completely different prognosis based on albuminuria alone is very important for us to recognize and act upon. Now, what I was talking about earlier, by the simple method of risk factor counting. Now, like we know in India, we are a country where patients come with multiple risk factors for that matter. 80% of our patients are going to be hypertensive, a great number obesity, a great number with dyslipidemia, and then follow the more advanced like CKD, CVD also as well, roughly around a fourth of all our patients. So we are a country who doesn't come with low risk profiles in terms of our diabetes patients. Majority of our patients are going to have multiple comorbidities. We are a multi-morbidity kind of diabetic population in our country. At least 2/3 of our patients are going to have combined comorbidities that arrive in a cluster. My patients will often ask me, oh, I had diabetes, now I've developed high cholesterol, now I've developed hypertension. Well, what I try to explain to them are that these are not conditions that come in silos. They are basically all best friends. One comes in a different form, affecting another organ. So all of these, like we know, tend to come in clusters. And at the same time, at least 1 in every 2 of our diabetes patients will turn out to have more than or equal to 3 comorbidities simultaneously. So if we all think of our clinic practices, if you think back, well, you'll find that all of our patients, age-wise or obesity-wise or dyslipidemia, hypertension-wise, a lot of them falling into this category. If you look even from an age-wise categorization, the first bar showing 18 to 39, so 30% of patients of age 30 and 70% of our patients of age 70 are going to have actually more than or equal to 3 comorbidities existing simultaneously. The sad news is that it's not only about the presence of these comorbidities. So that in itself is giving one level of risk, but 30% of our patients with diabetes have 3 or more risk factors which are out of target. So while having them is kind of conveying one level of risk, having them out of control just exponentially increases that risk again. So what is the point of sitting and counting all of these risk factors? What is it that we're trying to interpret? What is it that we're trying to understand? That the greater the number of risk factors, 3 and more, the higher is the chance of these patients getting an acute MI or of heart failure. If you look at that final statistic, which to me also, when I looked at that number, seemed mind-boggling, type 2 diabetes with 4 risk factors, a 232% increased risk of an MI, a 285% increased risk of heart failure. This is where our patients are going into, and that's why taking cognizance of the number of risk factors is extremely important so that we can take the right action right at the outset. Macroalbuminuria also is very common. For patients with type 2 diabetes with 3 risk factors, macroalbuminuria is present in 7.4% of patients, and make it into 4 risk factors, directly zooming up to a 30% of patients with macroalbuminuria. Now we know that albumin in itself is a mediator and marker, not only for worsening kidney disease, but for cardiac disease in itself. As a result of which, when this is something that crops up, you have albuminuria which is increasing. Again, important to take early intensive action. And again, for patients with this kind of subset, this highest risk phenotype in terms of what I would call it, type 2 diabetes with 3 risk factors plus a 340% higher risk of CV death. I don't think any of us have even realized that when you have that patient who is older, more than 55, obese, with hypertension, with dyslipidemia, this is the kind of number that we are dealing with. So this kind of patient, let's all understand, when this patient comes to our clinics, the onus on us is not only to get the A1C to goal. We have to look at the bigger picture, because these extremely high-risk patients deserve the best in this era where we have the armamentarium to get these patients, to protect their organs, to delay disease progression, to give them better quality of life. It is our responsibility to give them the right agents to get them to the right goals. So let's understand now, we've talked about the problem, let's see what are our solutions, what is the evidence in terms of managing this kind of high-risk group. So what we're specifically going to zone in on today is dapagliflozin with the innovator molecule Forxiga, which has an immense body of evidence in the form of what we're going to talk about over here. First is declare-TIMI. Of course, we have so many other trials also on the innovator molecule. But what's important to see over here is that in the declare-TIMI, what I'm showing you over here are the renal specific outcomes in the primary prevention cohort. So these are not patients who already had a pre-existing disease, but in the primary prevention cohort, as the number of risk factors went up, 1 risk factor climb up to 2 and climb up to 3, the renal specific outcomes actually got better and better. So the greater the number of risk factors, the greater was the risk reduction. So imagine for this kind of subset, type 2 diabetes with 3 risk factors, an 80% relative risk reduction where it came to renal specific outcomes for a primary prevention cohort. And I'm repeating that again. The overall reduction, well, you have a 49%, if you look across the entire population used over here, a 49% improvement. But again, the greater the disease risk rather, the greater was the protection. Same thing with the hospitalization due to heart failure. The greater the number of risk factors, again, the lesser were the number of hospitalization due to heart failure, and overall improvement, again over here, of a hazard of a 36% reduction also as well. As far as the KDIGO categorization goes, the use of Forxiga, again, in this high-risk type 2 diabetes population, a 59% risk reduction in the renal composite with the use of Forxiga. So again, over here, classification as per KDIGO, grades, and the greater the risk you have, the better, the greater is the outcomes with that also as well. The same goes for cardiorenal composites with the use of Forxiga, a 64% relative risk reduction for a primary prevention cohort. Forxiga also, and this was just an exploratory analysis, it improved albuminuria compared with placebo. Macro went to micro or normal. So what you're seeing again over here, just the addition of that drug, and we're not talking about glycemic improvement, we are talking again about albuminuria improvement, which greatly improves the risk. How much time do I have left? Are we done? Okay, so just one final word over here. The ADA now basically has explicitly given guidelines that for patients who have high indicators of CV risk, more than 55 or all the risk factors that we spoke about, it is not about patients with established CVD or established CKD, but if they have risk factors already, the use of these SGLT2 varieties with proven benefit needs to be started. Just one final line over here. Why is it that the innovator molecule makes a difference? Well, when there have been studies about generics versus innovators, the highest risk groups suffer the most. This has been proved with statins, it's been proved with clopidogrel. Again, bioequivalence requirements of these kind of generics is very, very poor as compared to the innovators. Do our high-risk diabetes patients deserve a substandard care? BioCreep, which is basically a cascading down of bioavailability as one generic, might use another generic as a reference. Again, for our high-risk kind of patients, do we really want to compromise on giving them substandard, unevidenced molecules? And finally, as far as the Indian requirements go, our dapagliflozin, which is classified as a BCS class 3, does not require human studies. It only requires in vitro studies to prove its equivalence. Again, with 650 different types of DAPA brands, do we really want to take a chance on these kind of patients? In short, these are patients with a 340% higher risk of mortality. What we really need to do over here is basically give them the best care in terms of our knowledge and our application. Let's give them, alongside with that, the best kind of molecule available in the class, which is your innovator brand of dapagliflozin. Again, a few slides just saying that it delays the need for cardiologist and nephrology referral, which all of us might have seen. So importance of risk stratification, why we need to focus on this group, why do we need to take a chance on this kind of patient? Let's give them the best. Thank you very much.
Thank you, Priya, for this extensive talk. I think the SGLT and GLP has really changed our mind, actually, how the diabetes has to be managed in cardiovascular risk. The questions will be in. I think the next speaker is Dr. V.K. Abhichandani from Ahmedabad. My friend, we had commonly shared once at the Surat. Actually, he is practicing Princeton University in the various trials, actually, post-marketing and initially in OAD and cardiovascular medical research. As a fellow of the Research Trust of the Diabetes India, fellow of the Indian Society of Hypertension and the Cardiovascular Society of the India, a senior fellow in Ahmedabad. He has a lot of publications, book, and there's a lot of publications, and he's going to talk on transformational metabolic medicine with a generative AI and predictive analysis. AI is coming in now every field, and he's going to talk about this. Over to you, sir.
So, honorable chairpersons and all esteemed colleagues, over next 13 to 15 minutes, I am going to take you through this allotted topic. My presentation will explore how advanced AI can transform metabolic medicine. Diabetes, obesity, and metabolic liver diseases are surging worldwide, and they are straining the healthcare structure all over the world. And our current care model, unfortunately, is often reactive, treating complications rather than preventing them. So AI combines genomics, lifestyle, clinical and environmental data to identify high-risk people. This allows doctors to provide personalized lifestyle adjustments and treatments before the disease actually develops. AI provides ongoing insights, forecasts the course of diseases, customizes care, and offers prompt advice to close gaps in access to specialists when paired with wearable technology and real-time monitoring. I would make this statement: artificial intelligence, the future is now. It's already here. And why? Because of explosion of big data like EHRs, wearables, genomics, and we have advances in generative AI, which includes context-aware text, image, and multimodal learning, and a very fantastic combination of cloud computing and federated learning enables secure, scalable adoption in our day-to-day practice. So what is cloud computing? Cloud computing refers to utilizing services such as storage, software, and servers over the internet, which is the cloud, instead of depending on our own computer or local servers. In metabolic medicine, it enables clinicians and researchers to access large patient data sets, run AI models, and share results on demand securely and at scale without the need for their own extensive IT infrastructure. Use of Amazon Web Services or Google Cloud to run a deep learning model that analyzes millions of liver ultrasound images instead of relying on local hospital servers is a good example of cloud computing. Federated learning is a machine learning approach where AI models are trained across multiple institutions or devices without centralizing the data. In healthcare, this is critical because patient data is sensitive and often cannot leave the hospital firewalls due to privacy laws. And these are two laws which are prevalent in USA and the UK respectively. Federated learning allows collaboration without breaching privacy. And a global model predicting diabetes complications, for example, could be trained using data from India, the USA, and the Europe without transferring raw patient files between the countries. Generative AI enhances efficiency and personalization for both clinicians and patients. How does it do that? It summarizes guidelines. For example, it converts complex ADA ESD standards into patient-friendly contextual advice, and it can draft clinical notes, discharge summaries, and referrals, thus reducing the clinician overload. And AI can generate culturally relevant diet charts, infographics, or counseling scripts, so that enables patient education. Predictive analytics, at the bottom I have inserted that. Predictive analytics shift the focus to anticipating diseases rather than waiting for complications. So for type 2 diabetes, predictive analytics can identify high-risk pre-diabetes patients before they develop into full-blown diabetes. Non-invasive tools are in place which forecast which patients will progress from MASLD to MASH or cirrhosis. Then AI and predictive analytics can predict the risk of myocardial infarction or stroke in patients with metabolic syndrome. And AI can also flag patients likely to miss doses, enabling proactive intervention. The AI can identify people who are non-adherent and thus can help us motivate the patients to remain more adherent to our advices. Then multi-layered data integration is the key to AI's power. So how is AI doing all this wonderful job? It can integrate clinical volumes, large volumes of clinical data, traditional EHRs, labs, drug prescriptions, genomics, metabolomics, and microbiome data. And it can integrate inputs from continuous glucose monitors, smartwatches, step trackers, and AI at the same time can analyze liver elastography, retinal photos, and MRIs. Field for AI in medicine. AI is already FDA approved for screening for retinopathy. Algorithms are in place to forecast low sugar events, especially in insulin-treated patients. Virtual assistants provide automated reminders and motivational nudges, and thus improve adherence. And a great combination of CGM plus artificial intelligence can provide real-time lifestyle advice, linking meals, sleep, and stress with glucose excursions. Nutrition and obesity is another area which can benefit uniquely from AI's personalization capacity. So AI analyzes food logs and metabolic profiles to tailor diets. AI can generate advice in local languages and culinary traditions. And AI can also predict for us who is at risk after, for example, bariatric surgery, for closer monitoring of that individual. And AI-assisted food logging automation can recognize images and allow accurate, effortless food tracking. And AI at the same time helps address a lot of has been said in the previous talks about MASLD and liver issues. So AI can help us address the silent liver epidemic of MASLD and MASH early and accurately. AI improves non-invasive staging of fibrosis versus a biopsy, and this is proved. And it can integrate genomics, labs, and lifestyle data, and these are all combined for precision and stratification of liver diseases. Trajectory prediction, that means AI can assist us in identifying muscle patients who are likely to progress to cirrhotic stage or unfortunately to HCC. And then AI helps us decide who needs medication versus lifestyle first approach. Whether do we go for the both the approaches at a go, or we can try lifestyle. So that is also informed by AI. AI in hypertension its role spans from prediction to precision care. The machine learning models integrate BP variability, genetics, lifestyle, and EHRs to identify patients at risk before. So in pre-hypertension stage, they are picked up. Wearables and Internet of Things devices like smart BP cuffs, watches, feed AI dashboards for real-time BP trend detection and anomaly alerts. Means any deviation will be picked up. AI clusters hypertensive patients into phenotypes. This is again very useful. For example, it can classify patients into salt-sensitive, nocturnal non-dippers, which helps tailor treatment pathways. Predictive analytics suggests best antihypertensive class per patient based on genotype-phenotype linkage and treatment response. So that's another area of research and benefit that is already being realized from AI. And AI-driven screening tools support national hypertension programs and identify underserved high-risk groups. So the epidemiologically also it comes of age and of great benefit. Then we can harness AI for cerebrocardiovascular prevention and management. So their deep learning can integrate imaging, labs, ECG genomics, and lifestyle to predict stroke, MI risk more accurately than conventional risk scores. We have been that certain risk scores were referred to by the previous speaker, but when AI comes into play, the picture becomes more reliable. AI interprets CT angiography, MRI brain, and carotid ultrasound to quantify atherosclerotic burden and detect subclinical disease. Wearable AI ECG patches detect atrial fibrillation, which facilitates timely anticoagulation and stroke prevention. Predictive models monitor adherence, optimize therapy, and prevent recurrent events. AI can highlight ethnic disparities, for example, higher stroke burden in South Asians, and thus support equitable precision prevention programs. AI also accelerates research in cycles. Research cycles are also facilitated. We can have literature summaries and instantly have an instant review of a manuscript, for example. And hypothesis generation is also helped by AI. AI can spot novel patterns across data sets. It assists in clinical trial frameworks and inclusion-exclusion design. AI helps in optimizing recruitment, and so it acts like a trial co-pilot. It helps in optimizing recruitment and adaptive trial monitoring. So, but we need to be we need to be aware of certain ethical issues. So we have to avoid bias, ensure AI works across ethnicities and age groups, ensure privacy, where federated learning really is of great help. Transparency. Models must be interpretable by us, all clinicians, and it should be worthy of our trust. And we need not over-rely on AI, as it is only a support tool, not a substitute for clinical judgment. And there are certain barriers like fragmented IT, many EHRs lack interoperability, and training gaps. We clinicians need to be AI literate. Cost is again a dampening factor in certain situations, and regulatory hurdles are there, but adoption barriers do exist, but we can address those through effective policy and planning. Now, before I end, honorable chairpersons, I'll quote few success stories. FDA-approved tool is widely used for picking up diabetic retinopathy. Mayo Clinic Google MASLD AI tool, which has been in use since 2023, detects fibrosis accurately. AI reduces readmissions. and real-time decision support for insulin titration is available in our endocrine clinics courtesy AI. AI can, convert complex concepts into it can simplify these concepts into animations. Chatbots are 24/7 available for answering patient queries. And gamification is another new upcoming thing where AI-driven incentive improves lifestyle adherence. And I have quoted 2 examples. They are available online. So generative AI boosts adherence by increasing engagement and motivation. And in future, digital twins will probably facilitate personalized disease simulation and intervention testing. Multimodal AI simultaneously can process labs, imaging, text, and lifestyle inputs. Federated learning allows global collaboration without data sharing. And real-time precision facilitates instant bedside decision support. So in conclusion, AI and analytics are transformational tools that move our care from reactive to proactive, and AI can help us focus on precision prevention and personalization. And combination of human and AI synergy is definitely going to ensure greater success in our day-to-day practice. Thank you very much. These were few references besides ones that I quoted in my slides, and thank you all for your patient hearing.
Thank you, sir, for the comprehensive talk on AI and use in medicine. We will take questions
Yes.
after the thing, sir.
Thank you.
Next section, I would like to invite a friend from Vasai, who's a dynamic diabetologist, Dr. Bensley Gonsalves. He is going to be talking on targeting insulin resistance, a cornerstone in type 2 diabetes management.
Thank you, respected chairpersons. And thank you, Dr. Manoj, Dr. Purvi, and Dr. Bansi for inviting me here. When we talk about type 2 diabetes in the Indian population, it is always about the insulin resistance because that's the main pathophysiology which we see and come across most of our thin, lean Indian patients. So these are my disclosures. So as the pandemic of diabetes is increasing, so is the burden, and so we need to pinpoint and treat to target what the patient demands. So it is the phenotype, what we look into, the diabetic phenotype, it is mostly the insulin resistance. Insulin resistance in Indian population came up as a theory. When Dr. Yagnik published this data, Dr. Yagnik has a very interesting data about the thrifty gene concept. What is thrifty genes? When a mother who is poorly nourished during her pregnancy will tend to have a baby who is underweight, and that baby once grows into an adult and is exposed to all the high calorie and the refined food. This kind of adults, this kind of babies who are born underweight to an undernourished mother may develop type 2 diabetes, mostly because of insulin resistance, because these babies are known to have fatty pancreas. More fat in the pancreas itself is resistant to the effect of glucose or insulin, and thereby there is decreased sensitivity of this pancreas to secrete insulin as a response to glucose. So this is how the insulin resistance in India, or rather the Indian phenotype, has developed. So looking into it in more in depth, Dr. V. Mohan has a very good study on this. That's the INSPIRED study, which wherein almost 19,000 individuals with type 2 diabetes across 9 states of South India with a duration of less than 5 years who had their first clinical visits were differentiated or identified as clusters of different types of diabetes. What was seen? 35.8% type 2 had mild age-related diabetes. 26.2% type 2 diabetes had severe insulin deficient diabetes. 25.9% had insulin resistant obese diabetes, and 12.1% had both combined insulin resistant and deficient diabetes. So which makes almost 38% Indian type 2 diabetic having insulin resistance as the underlying pathophysiology. So coexisting insulin deficiency and resistance makes these people more prone to micro as well as macrovascular complications. Specifically, what was seen in patients with insulin resistance and deficient diabetes was they developing retinopathy and other microvascular complications. So because of insulin resistance, all these pathologies, atherosclerosis contributing to ISD, stroke, PVDs, low HDL, increase in the thrombosis, inflammation in the liver leading to cirrhosis, excessive TG, high BP, hyperglycemia, visceral obesity, certain microvascular neuropathic changes, urinary frequency, headache, bloating, apnea, cardiomyopathy. So when a person is having insulin resistance, the risk of cardiovascular disease doubles, and 80% of these patients will die because of CVD. And this specifically is because of the pro-atherogenic effect of insulin. Insulin resistance will ultimately lead to hyperinsulinemia. So this itself will, which is pro-atherogenic and thereby lead to the cardiovascular events. Similarly, like peripheral insulin resistance, there is also the liver insulin resistance, which is the main reason for developing MASLD. My previous speakers were talking extensively on MASLD. Insulin resistance itself is a pathogenesis as well as it is a contributing factor to the progression from steatosis, steatohepatitis, cirrhosis, and maybe to hepatocellular carcinoma. So it is all the inflammation going on because of the insulin resistance in the liver causing the sequelae of MASLD. So signs and symptoms we see commonly is the abdominal obesity. Abdominal obesity is mostly because of the visceral fat, and it is associated with increased levels of insulin resistance in the skeletal muscles and the adipose tissue. Acanthosis nigricans, very classical. These are the velvety patches which are present on the flexor folds of our skin. It is classically seen in insulin resistance, can affect any age, men or women, and this pigmentation is because of hyperkeratosis. It is not because of increase in the melanin, it is hyperkeratosis in the skin. Then acrochondrons. These are also very commonly seen on the, also called as skin tags, fibromas, fibroepithelial polyps, mostly seen on the neck, on the, around the orbits, axillas, so associated with insulin resistance. So what investigations we do to identify insulin resistance? A lot of tests, very few which are clinically relevant. So the various tests of them are the fasting blood glucose and fasting insulin levels, from which we calculate the HOMA-IR value, then OGTT, HbA1c, then lipid profile, which will show a classical diabetic dyslipidemia, that is high TG, low HDL. The advanced markers are adiponectin, leptin levels, and free fatty acids. Now the gold standard here is hyperinsulinemic euglycemic clamp, which is more of a research kind of a test, not done in the clinical setting, and frequent sampling of intravenous glucose tolerance test. So the clinical indications are always the guiding path to how to identify a person walking into a clinic as whether having insulin resistance. So the waist-hip ratio, central obesity, classical, presence of acanthosis nigricans, very classical, and features of other metabolic syndromes like high BP, dyslipidemia, impaired glucose tolerance. So in practice, we use HOMA-IR, OGTT, HbA1c, and lipid profile, and the physical characteristic where we can identify the person is having insulin resistance or no. So drugs which deal with insulin resistance, the most important two, metformin, it reduces hepatic glucose output, increase peripheral uptake of glucose, first line, and the most specific, which we'll be talking more in depth, is the TZDs like pioglitazone. So it is a PPAR alpha gamma agonist, increases insulin sensitivity in the fat and the muscles, both in the peripheries as well as in the liver. Risk factors we all know. Then other drugs are the incretin-based drugs, GLP-1 receptor analogs, dual GLP-1 GIP receptor agonists, like tirzepatide, SGLT2 inhibitors, DPP4 inhibitors, and and other agents like statins, ACE inhibitors, ARBs. They improve the metabolic profile. Anti-obesity drugs, orlistat, semaglutide, even tirzepatide, when used as anti-obesity drugs, reduce insulin resistance. Of course, the main and the most effective is lifestyle along with the drugs, which has the best outcome. So talking about pioglitazone in depth, it is the only anti-diabetic drug that functions predominantly as an insulin sensitizer in the peripheries as well as in the liver. So though it may be the second or the third line in the as per the algorithm, but when a patient is predominantly demonstrating a prominent insulin resistance or propensity to have hypoglycemia, or he or she is having a MASLD, then pioglitazone should be considered maybe even first or second line. So the basic mechanism of action is it antagonizes the PPAR gamma and to some extent alpha, whereby there is gene transcription which causes increased hepatic glucose uptake, decreased glucose production, and thereby improving the tissue sensitivity to insulin. So various evidences which show that pioglitazone, it helps in CV mortality. So in this multi-database cohort study showed that pioglitazone is associated with a statistically significant 42% and 37% reduction in CV and non-CV mortality respectively. The more important study is the PROACTIVE trial, which was a prospective multicenter randomized double-blind placebo-controlled trial with 5,200 patients, 35 to 75 years, and these patients already had a pre-existing macrovascular disease risk. So these patients, we normally tend to avoid glitazones or any kind of thiazolidines in a patient who is already having a CVD. But this study had a patient who are at a risk of macrovascular disease. So primary endpoint was all-cause mortality like non-fatal MI, stroke, acute coronary syndrome, endovascular or surgical intervention, or coronary or leg arteries or amputations above the ankle. The secondary endpoint was time to the first event of death from any cause, MI, stroke, and cardiovascular death, and time to individual components of the primary endpoint. So what was seen, the primary endpoint, there was associated with a statistical trend towards improvement in these primary endpoints as compared to the placebo. Secondary endpoint, the main secondary endpoints of the key composite of all-cause mortality, myocardial infarction and stroke was reported as compared to placebo. When there was the subgroup analysis, there was reduction in MACE. Then compared to MI and stroke as compared to the placebo, there was a robust significant reduction in the risk of MI and recurrent stroke. So these are the key conclusions of PROACTIVE trial, wherein there is a high risk of macrovascular complications. Pioglitazone did reduce all-cause mortality and non-fatal myocardial infarction in such patients. So other than these other components, the metabolic syndrome components are very well taken care of by pioglitazone. It redistributes the fat from the viscera to the periphery, so thereby decreasing the visceral obesity. then reducing the BP, decreases TG, increases HDL. So all this is improved in pioglitazone. Specifically in NASH, though it is not the drug which is approved in NASH, but if we look at various studies, it improves the histological features of MASLD, reduces the steatosis, reduces the inflammation and ballooning without worsening the fibrosis. In the peripheries, it improves the insulin sensitivity in the skeletal muscles and the adipose tissue, and it resolves NASH. There are various studies, though it is not recommended but can be tried, because in India, saroglitazole is the drug which is only approved for MASLD, but on the similar lines, pioglitazone can also be tried. So to summarize, there is a high incidence of type 2 diabetes with insulin resistance. So lifestyle change and urbanization and specific drugs are the key to treating insulin resistance in our patients. It is associated with development of both macro and microvascular complications, and pioglitazone is the to-the-dot agent which improves the insulin sensitivity both in the peripheries as well as in the liver. So it is the optimal choice in our Indian patients. Thank you.
Thank you, Dr. Benny, actually, for talking this insulin resistance. The last speaker of the session is Dr. Ashish Dhengra. He's going to talk on SGLT and DT4 synergy, optimizing glycemic and cardiovascular. He's actually diabetes, thyroid, and obesity specialist, director of the Mahi Diabetes Thyroid Care Research Center, Jabalpur, Diploma Diabetes and Cardiac Industry, UK, and fellow RSDI and fellow Diabetes India, SCP Diabetology, All Institute of Diabetes, Asia Hospital. Ashish.
Thank you, respected chairpersons. And in the coming few minutes of journey, I will be going through the J and Viru combination to combat the GABBR, that is CRM, cardio-renal metabolic dysfunction. So we are here to discuss the two combinations, drug combinations, that is SGLT2 inhibitor and DPP4 synergy, optimizing the glycemic targets. It is supported by Abbott. So the goals of diabetes care, what we require, why we are giving medicine to a patient. Patient आपके पास आता है, पूछता है हम दवाई क्यों लें, हमें तो कुछ होता ही नहीं है. So the answer is to prevent the future complications. So basically we were having the older molecules which were not having the property of controlling all the pathophysiological pathways. But when you combine this J and Viru, that is DPP4 inhibitor and SGLT2 inhibitor, they work together to combat the GABBR, that is the hyperglycemia and its associated complications. So goal of diabetes care is to prevent complication, and when the complications are less, you will have good quality of life. So my dear friends, the cardiovascular burden in India, as per the studies, it is very high when the patient is coming to your clinic. Of the newly diagnosed type 2 diabetic patients in India, 39.5 were classified as having high risk and 60.5 were classified as very high risk based on Lipid Association of India criteria. On average, patients had 1.7 plus minus 0.9 major ASCVD risk factors as per the study. So why we are here to discuss this combination? Because 40% of diabetes patients develop diabetic kidney disease, and approximately 1 in 3 adults with diabetes have CKD, and more than 80% of ESRD is caused by diabetes, hypertension, or a combination of this. So CKD in people with diabetes reduce the life expectancy by 16 years. So it is a very big number. So for preventing the complications, approach should be targeted at multifaceted levels. The glycemic target, the cardiovascular risk factor management, weight management, and the cardiorenal protection, glucose lowering agents which are having the cardiorenal protection should be taken care. So my dear friends, the CRM pathway, a lot is talked about this nowadays. The CRM interaction, the primary baseline is hyperglycemia, insulin resistance, as Dr. Bensley was talking, that it is a very, in the initial stages, if we are having the thripty gene hypothesis and all those things leads to hyperglycemia due to insulin resistance, oxidative stress develops, neurohumoral and inflammatory response. All these cascade lead to CKD and heart failure, cardiac fibrogenesis and renal fibrogenesis. So we have to target this pathophysiology in early stage. So complex hemodynamic, neurohumoral, hormonal and the biochemical changes occur in the heart failure and the chronic kidney disease patients and diabetes, which further aggravates with multifactorial pathogenetic mechanism. So we have to combat this CRM pathway by optimizing the glycemic and cardiorenal outcomes with this combination of SGLT2 and DPP4 inhibitor. So what is the rationale? Why it is a very good combination after metformin? The rationale for Empalina FDC, we know that they have the complementary mechanism of action. As in Sholay, you have seen the Jay and Viru. They were a little bit naughty that Jay was against Viru and then sometimes Viru was against Jay. But here they are complementary and they are having the good combination for reduction of HbA1c, fasting and body weight. So what we require? We require a good control of glucose along with weight reduction. Apart from that, it has pleiotropic benefits, what we will see in the coming few minutes. So SGLT2 and DPP4 fixed drug combination, it has the complementary on multiple fronts, the pleiotropic benefit, and especially in the Asian Indian phenotype, which is having high visceral adiposity, early beta cell dysfunction, increased cardiorenal risk. Many patients coming to our clinic, कि मुझे तो 4 साल से ही diabetes है, and all the parameters are deranged. So that is the Asian phenotype, which is pushing us towards the bad pathway. So targeting the multiple pathophysiological pathway, that is the omnious octet, that is very important. It is taking care of gut problem, liver decreases hepatic glucose production, pancreas decreases glucagon production, increase the insulin release. In muscle, it is increasing the uptake of glucose and the glycosuria, and it is through the kidneys, and it is causing the weight loss and decrease in the blood glucose levels. So dual inhibition, it has multiple effects, and ultimately it leads to decreased weight, systolic BP, hyperglycemia is decreased, and weight neutrality is there of the DPP4 inhibitors. So they offer the glycemic and extra glycemic benefits like weight loss, BP reduction, and improved insulin sensitivity. So that is the main thing which we require for prevention of future complications. So the expert recommendations and clinical guidelines, they have shown when to initiate the SGLT2 plus DPP4 combination. When the patient is drug naive with HbA1c more than 8, but metformin is contraindicated. When the patient is on metformin, but it is uncontrolled with HbA1c of more than 8.5, patients with high CV risk and CKD or heart failure, and those who are requiring or searching for weight loss medicine or hypoglycemia avoidance. So that is the combination which should be used. What are the advantages? We can see robust reduction in HbA1c, sustained and rapid control, proper adherence. What is the problem in India? The poor adherence. सर आपने 4 दवाई दी थी तो हम तो एक सोचे है ही नहीं, वो तो 1 महीने आपने लिखी थी, उसके बाद तो हमने खाना बंद कर दिया. तो वो उससे पूछो कि पहली वाली क्यों चला रहे हो, तो बोले पहला तो पहला ही होता है, दूसरी हमने बंद कर दी. So the pill burden, which is very important thing in our Indian population, there is improved adherence with single pill, cost effectiveness, and addresses clinical inertia and supports early intensification. So what are the trials showing with the EMPA cardiorenal outcomes? I will not go in detail because everybody knows it. That is EMPA-REG outcome, 14% relative risk in 3P MACE, 38% CV death, 35% hospitalization to heart failure, and 39% to worsening of nephropathy is reduced. Then EMPA-REG renal study have again shown whether it is in the stage 2, 3 or 4, it has shown the positive benefits. EMPA may be suitable treatment for patients with type 2 diabetes and stage 2 or 3 CKD for reduction, preventing the future reduction in the eGFR. So EMPA-REG kidney key findings, the empagliflozin led to lower risk of progression to kidney disease or death due to the CV causes compared with placebo in a wide range of patients with CKD at risk of disease progression. So it is helping to prevent the future complications and progression of kidney disease. So IMPULSE, which has shown the EMPA use for stable patients hospitalization for heart failure, what were the primary endpoints? Were the composite death, total heart failure events, time to first heart failure event, and change in the KCQ total symptom score. So all were showing the positive benefits. EMPA in acute infarction, the ME trial have shown when the EMPA 10 milligram was compared with the placebo, they have shown the improvement in the LV ejection fraction, end diastolic volume was decreased, and anti-proBNP was reduced. So it has shown the positive benefits in MI population also. Now moving to the second, that is the Viru, linagliptin, the glycemic cardiovascular and renal outcomes, we all know, again it has the positive benefits that HbA1c reduction with lina is very good. When you see with the pioglitazone, it is giving about 1, and with the alone linagliptin is having 0.4 to 0.7. So my dear friends, with the combination therapy, lina, EMPA and metformin, we can get 1.9% reduction of HbA1c. So that is a robust reduction. So pooled analysis from 15 phase 3 trials in Asian population of the changes in HbA1c with linagliptin, they have shown the good reduction in across all the studies. Now 58.2% of Asians were Indian patients in this study, and Asians had very good reduction in contrast to the Japanese and white. So the DPP4 enzymes reduction, inhibition reduction is better in the Asian population with linagliptin as compared to the other population. So lina is the broadest clinical evidence of use. You can use safely. आँख बंद करके, जैसे हमसे पूछते थे कि पीजी जब करते थे तो छोटे बच्चे जो आते हैं फर्स्ट ईयर में कि सर बीपी की दवाई सबसे कौन सी दे सकते हैं आँख बंद करके. So amlodipine you can give in any patient. Like that, linagliptin can be given in the cardiac patient, renal patient, any liver disease. You can give in any patient. So convenience of OD dosing without the need of dose adjustment. Safety of MACE outcome proven in the CVOT trials. In this you can see that Carmelina trial have shown the hazard ratio was less than 1 in the linagliptin arm. So Carmelina have shown no increased risk of hospitalization to heart failure with linagliptin, and albuminuria reduction was also seen with Carmelina by 14% lower risk of progression of albuminuria. Subgroup analysis from Carmelina have shown the numerically lower hospitalization to heart failure risk in certain subgroups of Asian population, South North American, and in the Asian population again 53% reduction was seen. It can be used in mild renal insufficiency, moderate, severe, ESRD, or on the transplant patient. In every phase of the renal dysfunction, it is giving the good reduction of HbA1c. Now clinical evidence of combination, again the combination have been studied by n number of studies, while combination of 25-5, 10-5, only 25, all the combinations have been studied by double-blind study, and they have shown this fixed up combination as a second line therapy for 52 weeks significantly reduced HbA1c, fasting and body weight. So what we require? We require the agent which is taking care of all the pathophysiological phenomena. So this is the 24-week trial, 1.9% reduction with metformin when both were combined. Now with the inadequately controlled with metformin when they were added on the lina alone, and when the EMPA was also added, so reduction was much better. So to summarize, the SGLT2 DPP4 synergy in type 2 diabetes, that is the Jai-Viru synergy, we have seen since the decades. So type 2 diabetes is a growing global epidemic with high cardio-renal burden. So CKD affects 1 in 3 adults with diabetes, and CVD risk is significantly elevated in diabetic population. We say when the patient is diagnosed with diabetes, it is MI equivalent. So from the first day, you have to take care of the patient as he is having myocardial infarction. So empagliflozin, proven CV renal benefit, decreased CV death by 38%, hospitalization to heart failure by 35%, and nephropathy by 39%. Lina, safe across all the renal spectrum, no increased hospitalization to heart failure risk by Carmelina, decreased albuminuria progression was seen, and consistent HbA1c reduction. So fixed drug combination of lina and EMPA, they have complementary mechanism of action with good reduction of HbA1c and reduction in the body weight and complications. So SGLT2 DPP4 synergy, why this combination matters? Because it addresses the Asian Indian phenotype with high visceral adiposity, early beta cell dysfunction in Asian population, and increased cardiorenal risk. So target multiple pathophysiological pathways, it is the omnious octet which we require. So that is the beauty of this molecule, that it offers glycemic and extra glycemic benefits apart control of hyperglycemia also. So the clinical benefits are reduction in HbA1c up to 1.9% in drug-naive patients and effective as an add-on to metformin or in metformin intolerant patients. So my dear friends, what is the beauty of this drug? That with metformin, if you are using it, you are not doing harm to the beta cells, you are improving the sensitivity and preventing the future complications. So the pleiotropic benefits along with the reduction in HbA1c, it is the beauty of this Jay and Viru combination. Thank you.
And TDP are both complementary to each other. They not only help the cardiovascular, but actually reduce the urinary tract infection also by combining.
Yeah,
that's one good part of it, actually, the combination. I think we have a few minutes. If anybody has any questions or any comments on these talks, I think we can just take. Dr. Abhijandani is here still, and I think anybody has any. He talked a lot on AI and all that thing. Dr. Bensi is there. So any of these talks related. GLD and BT inhibitors, what talk was there when Sales talked on the insulin resistance, and Dr. Abhijandani talked on the AI role. I think AI is going to play a big role in the future. Actually, he's already told not only the cardiovascular, the ECG changes are also going to be interpreted, the echocardiography, radiology is going to change, and of course in the diabetes and MAFLAT, you see the fibroscan, Mayo presentation, all that thing has making a lot of change, making ease and accuracy is increasing. In fact, one of the echoes which was subjected to the AI, and it gave only one diagram, amyloidosis, it turned out to be amyloidosis only. That's what the accuracy be. From ECG, you can make out which patient going to go atrial fibrillation, which going to get a stroke. I think much earlier before our human eye can make it out. I think these are going to be changes of the future generation. So anybody has any comments? I think
regarding pioglitazone, Dr. Samsalil, one side it increases weight and another side it is given for the obesity. How do you?
So we are talking more of the visceral obesity, sir. So when we are targeting visceral obesity, we are targeting more of the insulin resistance, and no drug takes care of the visceral insulin resistance at the viscera as well as the periphery than pioglitazone. Moreover, it will cause redistribution of the fat. There will be the side effects of water accumulation, but there will be redistribution of fat from the viscera to the peripheries.
I would like to add to that whatever he is saying. So weight gain generally are not more than 2 to 3 kilos from the previous one. Once the sugars are controlled, anyway somebody is developing weight gain. And second point, it prevents and keeps your multiple pathological conditions so that the complications are like you live longer 4 to 5 years. What if he gains 2 to 3 kilo weight? That's what the content is.
Sir, pioglitazone is a wonderful drug. जब सीटाग्लिप्टिन ने बैन करवाया था, all the patients sugars went up to 300, 400. और जो पेशेंट पायोग्लिटाजोन लेता है वो आपके पास 5 साल नहीं आता है, लेकिन वो 50 पेशेंट भेजता है. तो ये वो बहुत तय है कि आपको पायोग्लिटाजोन से वंडरफुल दवाई डायबिटीज में कोई नहीं मिलेगी. It has the robust HbA1c reduction of 1.5%. The patient is controlled for 4, 5 years without any complications. So it is a very wonderful drug.
It's a very good drug, and I think underutilized because of the fear of the weight gain or heart failure. I think the 7.5 and 15 milligrams you have been using doesn't have any, I think, major side effects as such weight gains and heart failure, except at a very stage 3-4 heart failure. Maybe a little careful you have to be. Otherwise, wonderful, good control of diabetes and all the. I think
Sir, may I add just one comment to whatever I could share? That while using ChatGPT now, the 5th version is also available to the paid ChatGPT for users. So we have to just master the art of prompting. And otherwise, the AI can hallucinate and give you really wrong answers, wrong references. So that is something. Thank you.
So I would like to ask for pioglitazone. Especially for post-menopausal women, what is your take? Like, should we continue or do the DEXA scan first? What is your take on that?
There is one important side effect of pioglitazone, that is bone mineral density loss. So always, for such a high-risk patient, we would always do a DEXA scan If she is at a risk of developing fractures, then we correct with alendronates or bisphosphonates, and accordingly start with a low dose. 7.5 it's available in India, so go with 7.5.
But it is usually the clavicular fracture mainly, but not the whole body. And pioglitazone weight, if you are worried, sir, you give her Emifru half tablet for 15 days, her swelling will go and weight will also come to low by 2 to 3 kgs. Don't use Ditor or anything. Emifru will work, no other drug will work. This fact has been not known by many physicians. So we have to use Emifru for pioglitazone swelling reduction.
And madam, may I add to your question?
Pardon?
That it's only if there is a compelling indication to use pioglitazone, then only consider it in postmenopausal osteoporotic ladies. Otherwise, you have better options available. So,
thank you so much.
No more questions. I think we'll end the session here. Thank you all the speakers.
Thank you, respected chairpersons. हर बार मुंबई सेंट्रल बॉस का आई थैंक यू सर आ जाइए आगे भैया एक ऐसे लो सब लोग ऐसे लो थैंक यू.
So with that, we end this wonderful and interactive session. Up next, on behalf of the DRS Organizing Committee, I would like to invite everybody to join us in the next hall for the valedictory function, which is followed by high tea. Thank you. Thank you.